Okay, so I'm recording. Um, Go Philadelphia sports teams, basically. But we're gonna do GI anatomy and questions. I also threw in histology and I also threw in blood supply. It's gonna be a lot of stuff in here. So if you guys have any questions throughout this, please stop me because everything's gonna build. Okay, here's my general reminder. Whatever I say is like important to know or high yield is just like what I think personally, not like, what's on your exams. I have absolutely no idea what's on your exams. Okay, so how I kind of did this was GI anatomy. I'm gonna start with endocrine and exocrine organs. So remember, endocrine organs, these are things that secrete hormones directly into the bloodstream versus exocrine organs, they like secrete things that go through glands. So like the pancreas is both endocrine and exocrine because so you'll cover the pancreas in endoblock as well because it has that endo function. Because it makes insulin that goes directly to the bloodstream, but it also secretes these pancreatic juices, these enzymes, and that gets secreted via ducts and glands. So that's why it's exocrine. But I kind of lump them all together, but I'm talking about the liver, the gallbladder, and the pancreas kind of separately. I just kind of group those like a little bit differently. And then blood supply. And if time, I want to go through portosystemic anastomoses, which is a mouthful to say. But it's basically like pathology of blood supply. So you can imagine that's super, super important. And then innervations, and then like a few questions. Okay. So GI organs. So everything in the GI tract is mouth to anus, and this is what everyone says. People don't think that they should be studying the mouth. They really just think of like the stomach, the colon, but like that's why mouth, salivary glands. It's all on probably on your study guide. But think of oh my god, mouse, esophagus. Oh god, think of the mouth. I'm in lab too much. Think of the mouth and the esophagus kind of as like separate entities. And I'll go kind of into it, but everything else is either going to be a part of the foregut, the midgut, and the hindgut. And if you think of all these other GI organs as being a part of the foregut, midgut, and hindgut, that'll really help you for OMM because you're going to start getting into like GI stuff for OMM. By the way, I put up a study guide in the drive under OMM. Okay, so it's kind of like a GI OMM study guide. It's really good. I use it for boards too. Okay, so this is kind of like if we were just kind of look at an image of the GI tract, this is how it would look. And the first thing I want you guys to remember, anatomy brain, always anatomy brain. So this is going to be the right, this is going to be the left. So we have the liver, the stomach, the pancreas, gallbladder, the cecum, the ascending colon, transverse colon, descending colon, sigmoid, rectum, and anus, and then the small intestine. So duodenum, jejunum, and ileum. Ileum connects to the cecum. We'll talk about that. And then the appendix is a part of the cecum. It's like a little thingy off of the cecum. So the first part of the large intestine. And kind of like something that's kind of important with GI anatomy is understanding the quadrants. So if we were to separate this into quadrants, it would kind of look like this. And this is straight up, they can ask this on boards on your exam just as like filler anatomy questions, like what quadrant would the stomach be in, or the liver, or the cecum, or things like that. So just keep in mind like what would be located in each of these quadrants. And the reason they think that like the reason this is so important is because someone comes in with like right lower quadrant pain, you're like, okay, well, like it can't be the liver. Like the liver is not going to be right lower quadrant. So it's just kind of important to know what's here, and you can kind of like start making differentials that way. If someone comes in with right like upper quadrant pain, something about the liver needs to be on the differential. Same with left upper with the stomach, and then the diverticulitis usually occurs down here in this like the sigmoid colon. So if someone comes in with left lower quadrant pain, that should be on your differential. Okay, so just kind of like have this memorized roughly, just like which organs are in which quadrants. And then, so those are the typical quadrants. So right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. But then there's also these, they're not really quadrants because there's 9 of them. But this is really important in terms of referred pain. So we're going to talk about like referred, it's like the last thing we're going to mention. We're going to talk about referred pain. But basically it's like, let's say you have, I'm going to go back really quick. Let's say you have stomach pain, like your stomach hurts. You're going to feel it in the epigastric region. So someone will come in and be like, oh, I have epigastric pain. So it's kind of like the quadrants, but it gives you like a little bit more information. And these are just terms you just need to, again, memorize. They're just straight up, it's just definitions to just memorize these. So again, right side, left side. So the epigastric is going to be the upper, like the highest of these. Then the right hypochondrium, left hypochondrium, umbilical region. This is going to be more of like the mid-gut organs. Again, we'll talk about that later. And then right lumbar, left lumbar, and then the hypogastrium. This is like very, very low stomach pain. This would be something like you have like colon pain would be down here. And then the right iliac region, left iliac region. And again, like I said, a lot of the times, a lot of referred pain, it'll be like in the epigastric region, umbilical region, or hypogastric region. Okay, so foregut, midgut, hindgut, super important. You need to know this. This is for OMM too. You do just need to know what organs are located here, but it's actually good because it helps you with blood supply. It helps you with innervation, because certain blood supply, like sometimes it'll just say like, oh, the celiac trunk innervates all the foregut organs. So like knowing which organs are in the foregut is really, really helpful. And in terms of like what's the foregut, midgut, and hindgut, we'll talk about that with embryo. But for now, it's just understanding which organs are in there. And roughly, it's like the upper GI tract is going to be in the foregut. The middle GI tract is going to be in the midgut, and then the lower GI tract is going to be in the hindgut. Okay, so you can kind of see where it separates. What's kind of weird though is like where it switches from like small intestine and large intestine. So for example, in the foregut, the first and second parts of the duodenum, which is like the first and second parts of the first part of the small intestine, are foregut, but then the last two parts of the duodenum are midgut. And then the rest of the small intestine is in here. And then for midgut, you have cecum, ascending colon, and then the proximal 2/3 of the transverse colon. So if the transverse colon, again, is like this, it would be like these proximal 2/3, like the closest to where like the ascending colon is over here. So it would be like the transverse colon, this would be midgut, and then it switches to hindgut, so the distal half. Or I guess that would be 1/3, whatever. And then descending colon, sigmoid, rectum, and then this is the anal canal above the pectinate line. We're going to talk about what the pectinate line is. It's a classic, love to ask questions about the pectinate line. So we're going to do that at the very end. But just understand it's above the pectinate line. Okay? Okay, so have these memorized. I'm going to come back to this as many times as I can, because these will be like your OMM questions as well. And then just kind of like diving into it, if you think about the whole GI tract as like a linear system, not all like smushed together, you can kind of see it's like upper, middle, and lower. But why, again, it's important to think about the grouping these organs is because of the blood supply. So all of the foregut organs, so the esophagus to the second portion of the duodenum, and this is known as the ampulla of Vater. We'll talk about that in a little bit. It's the second part of the duodenum, is like it's an important landmark basically of the duodenum. So that's where the pancreas enters, it's where the bile duct enters, but we'll talk about that. But all the foregut organs are supplied by the celiac artery. All of the midgut organs, so the lower, like the last half of the duodenum, all the way down to those proximal 2/3 of the transverse colon, are supplied by the superior mesenteric artery, or SMA. And then all of the hindgut organs, so that distal 1/3 of the transverse colon, all the way to the anal canal above the pectinate line, is supplied by the inferior mesenteric artery. And if you guys remember from cardio, these are 3 big branches off of the abdominal aorta, which we'll get into as well. Okay, but we're going to go into this in a lot more detail when we get to blood supply. And then other kind of like landmarks, again, really emphasizing right and left, because I'm telling you, Dr. Cooley especially, she will try and get you guys with like you're going to learn about like hepatic versus splenic OMM techniques, and you will literally fail your practical if you're on the wrong side of the patient, because the liver is on the right side and the spleen is on the left side. So it's just really just grill it in your head as much as possible, okay? So the main things I would say, right versus left, would be like liver and gallbladder, that's on your right side. Stomach and spleen, those are on your left side. And then just kind of looking at like the colon, for example. So we're looking at the colon here. The ascending colon kind of bends a little bit before it turns into the transverse colon. This is known as the hepatic flexure because the liver's like right there. Okay, so that's on the right side. And again, it's another landmark. If they're like, oh, it's the colon, like the hepatic flexure of the colon, you know that's the right side of like the colon where it transitions from ascending to transverse. The splenic flexure is on the left side. This is where the transverse colon kind of turns into the descending colon. That's the splenic flexure because the spleen is right above it. Okay, so just, again, with these landmarks, right and left, very important. And I say it because I have friends that literally have failed OMM practicals because they did the technique perfectly, but it was on the wrong side. They're like, yeah, your liver's on the opposite side. And they're like, okay, yeah, you're right. Okay, so So basically, histo's not terrible for this block. I mean, it's kind of like annoying, but all of the GI organs pretty much have the same histology. And Costanzo does talk about this. I know she does go into this, but I do find it a little, I did find it a little confusing at first. So kind of like just wanted to go through it very quickly. So basically, GI organs have 4 layers, and all GI organs have 4 layers. There's one exception with the stomach, but we'll talk about that. So again, like I said, from mouth to anus above the pectinate line, you're going to have these 4 layers, okay? So the first layer is the mucosal layer. This is the innermost layer. The mucosa itself has 3 additional layers, okay? So you have the epithelium, the lamina propria, and the muscularis mucosa. These are all a part of the mucosal layer of these 4 layers. The next layer is the submucosa, so it's just right below, well, technically above the mucosa. And the important thing to understand about the submucosa is that this is where Meissner's plexus is located. So Meissner's plexus, this is one of the enteric, like, nervous system plexuses that you need to know for this block. And it's just like the GI system has its own nervous system, which is kind of cool. But I know Costanzo talks about it, so we're not going to go into the physio too much. But I did put on here, like, this is implicated with Hirschsprung's disease. This is something we're going to talk about with embryo, the embryo path lecture. It basically is like you don't have Meissner's plexus, and that's why it manifests with Hirschsprung's disease. The next layer, this is basically the muscular layer. This is known as the muscularis externa. And I'm going to show you what is meant by this, but sometimes people will talk about the muscularis externa as being inner circular, outer longitudinal, and it just means basically like the type of muscle that's there. The inner layer is circular muscle, and then the outer layer is longitudinal muscle. However, in the stomach, there's an additional muscular layer called the oblique muscle, and that's only in the stomach, okay? And again, I'm going to point this out so you can visualize it. But the muscularis externa layer contains Auerbach's plexus. So Auerbach's plexus, this is another type of GI enteric nervous system control. And another name for this is myenteric. So Meissner's sometimes goes by submucosal plexus. They're the same thing. Submucosal plexus, Meissner's, same thing. Auerbach's sometimes goes by myenteric, and they're just trying to say it's like muscular. It's like myenteric means muscular. So it's just saying like, oh yeah, it's in the muscular layer. And then the outermost layer, this is the adventitia/serosa. It's going to change based on what organ you're in. Like they're the same thing, it's just they're called different names if it's lining a cavity or if it's lining like a tube of some sort. But they're the same thing. So if you see either one of them, they're talking about that outermost layer. Okay, so here's a picture. Again, so notice esophagus, small intestine, colon. So besides the stomach, they're all going to have this pretty much the exact same 4 layers. So the 4 layers I've highlighted in red. So we have the mucosa, this is the innermost. We have the submucosa over here. This is the one right above it or below it. We have the muscularis propria, which is basically the muscularis externa, and then the serosa over here, /adventitia. So from here, the first thing I wanted to point out was the mucosal layer has those 3 layers. So there's an epithelial layer. This is just what type of epithelial cells make up the GI tract, and it's going to be non-keratinized stratified squamous. Okay, so this is just like a good thing to know. You guys will like eventually learn about a pathology state called Barrett's esophagus, and it's when it turns from this cell type to another cell type. It's a favorite on boards. I was asked it on both sets of boards. So just understanding that non-keratinized stratified squamous epithelia is the normal epithelial like cells found in the GI tract is important. Then within this mucosal layer, the second like layer within that layer is the lamina propria. We're going to talk about this a ton with immuno. It just has like a bunch of immune function. And then the muscularis mucosa is just like the muscular layer of the mucosa. Jumping down to the submucosa, this is going to be where you find Meissner's plexus, aka the submucosal plexus. So that's what number 7 is. It's what these yellow circles are. And then I wanted to point out here is where you have the additional oblique layer of the stomach. So the stomach, number 6, this is like the oblique layer that's in addition to the inner circular outer longitudinal. Okay, and to understand the inner circular inner circular outer longitudinal that's the muscular layer. So here's the muscular layer with the muscularis propria is this whole thing here. And basically it's saying like the inner layer of the muscularis propria is made up of circular muscle. And then the outer layer of the muscularis propria is made up of these longitudinal muscles. So if you see inner circular, outer longitudinal, it's only the GI tract, and it's the GI tract muscular layer. But the stomach does have this additional oblique layer, just in addition to the inner circular, inner circular outer longitudinal. But within the muscularis layer, we have that second plexus. We basically have Auerbach's plexus, aka the myenteric plexus, and that's number 8. Okay, so that's going to be, I don't think it's super important to know like which of the two, like is it in the inner circular or outer longitudinal? It's just in the muscularis propria layer. It's just in that muscular layer. And then finally we have the serosa, which you can see is called like adventitia in certain organs, and then it's called just serosa in other organs. They're the exact same thing. It's very just semantic. It's like if it's lining like a tube, it's going to be adventitia, and if it's not lining a tube, basically it's going to be called serosa. I think that's everything. Okay, but this is basically the entire GI tract. So when I'm not going to really go into too much histo in addition to this. This is like the main histology to understand. I am going to bring up a little bit more histo when we talk about the liver, especially the liver. But this is pretty much just all of the GI tract histo. Here's another picture to kind of see it, like not in cartoon form. Well, I guess this is technically a cartoon, but like kind of like how it looks if you were to like peel back the layers one by one. So again, remember mucosa, innermost layer. There's 3 layers to the mucosa. Then you have the submucosa. That's where you have your Meissner's plexus. Then you have your muscularis plexus, inner circular, outer longitudinal. If we're in the stomach, we additionally have those oblique fibers. And then that's also where the myenteric plexus is, aka Auerbach's. And then finally we have the, serosa or the adventitia. Okay, so this is the general scheme of the GI tract histology. Okay, so then I wanted to go into the mouth and salivary glands because remember I said kind of think of the mouth and salivary glands as like their own separate entity. This is kind of what I mean. They don't really have that inner circular out, like they don't really go through that. But very briefly, because I don't think it's super high yield, but very briefly, the mouth is divided into 2 sections. So there's the oral vestibule and then the oral cavity proper. When they're talking about the oral vestibule, they're talking about like the buccal mucosa. So basically where the cheeks are on the inside, where the cheeks are, where the lips are from the inside, the anterior surface of the teeth and gums facing the cheeks. That's the vestibule. The actual cavity is going to be kind of like in the mouth. So the posterior surface of the teeth and gums, the soft and hard palates, and then the floor of the mouth. Sorry, one second. Okay, so the salivary glands, these are exocrine glands. So again, remember exocrine glands, these are things that secrete some sort of enzyme, just they secrete something that goes through ducts. That's exactly what the salivary glands do. And they have 3 major ducts or glands. And you're going to go into this way more second year. That's why it's like, okay, like just kind of understanding what these are for now is fine, but you'll go into a lot more depth second year. Like you'll go into like the cancers of the salivary glands and stuff. But there's 3 glands. So the parotid gland, that's probably like the main gland, like the main salivary gland. This is secreting fluid directly into the vestibule. So you can imagine that's like your main saliva guy. Then you also have the submandibular and sublingual glands. The names actually tell you where they're located. So submandibular, the mandible's the jaw. So the submandibular glands are going to be like right here. And then the sublingual is going to be under the tongue, lingual's tongue. So those 2 are secreting fluids into the saliva, into the oral cavity proper. And just to kind of visualize it, you'll go into kind of like head and neck anatomy a little bit when you get to neuro. I'm sure we'll cover it when we get to neuro. But basically just wanted you to see the location of the gland. So here's the parotid gland's massive. So this is the parotid gland, and then here's the submandibular and sublingual glands. Okay, so just kind of visualizing it. Okay, and then the esophagus. So the esophagus is what's going to connect the pharynx to the stomach. So it's like all the way back to the back of the mouth, the back of the throat, down to the stomach. That's your esophagus. We did talk about this in terms of like understanding what's going through the diaphragm at what levels. Remember that the esophagus is at T10. So just kind of review those. And then there's 2 sphincters that are important. Well, one's more important than the other, but the 2 esophageal sphincters are the upper and the lower, which is nice. So the upper, actually, I think I haven't. Oh, no, I don't. So the upper esophageal sphincter would just be like the top, like up here. And then the lower esophageal sphincter is going to basically be where the esophagus transitions from esophagus to stomach. There's like a clear delineation. I'll show you when we get to the stomach. but that's kind of like the lower esophageal sphincter is very important to not let gastric juices flow back up into the esophagus. So if you know people that have GERD, aka heartburn, they probably have like a very weak lower esophageal sphincter, because all heartburn is like the stomach juices flowing back up through the esophagus. Okay, but histology is actually important for the esophagus. So, and I think again, Costanzo does talk about this. The upper 1/3 of the esophagus is made up of striated muscle. Remember, striated muscle is basically just skeletal muscle. It's attached to your vertebra. Well, not your vertebra, but like to bones and stuff. So that's striated muscle. It's important to understand that the top 1/3, this is voluntary control. So you have control over that upper 1/3 of food like going down there. The bottom 2/3 is made up of smooth muscle. And remember, smooth muscle is completely involuntary. Like, you have no control over smooth muscle. Like, you don't feel like you don't tell the body to undergo peristalsis. Like, it just does it. And it's because it's under involuntary control. But just kind of understanding the upper 1/3 is voluntary control, and then the bottom 1/3 is involuntary control, because it changes muscle type from striated to smooth. And that's why we get peristalsis in the esophagus as it's going to the stomach. But I put this here to kind of like keep this in mind as you're going through future blocks. There's some diseases you're going to do in neuro, because neuro is kind of like neuro MSK. These diseases in neuro affect striated muscle. And of course, it's throughout the entire body. But since the esophagus has that upper 1/3 of striated muscle, the patient may have issues swallowing. So it's just kind of like a cool tie-in to like remember, like, oh yeah, the esophagus has striated muscle. Like that can be affected by this disorder. But here's kind of like just another picture of it. So again, the upper 1/3 is going to be striated muscle, and then the bottom 2/3 is going to be smooth muscle. And then this is just I don't think they'll ever make you like, oh yeah, that's striated, that's smooth. I don't think they'll ever do that, but just kind of like, again, visualizing it. Okay. So next is the stomach. So the stomach is divided into a bunch of, divisions, and they kind of change based on blood supply. So we'll talk about this a lot more when we get to blood supply, but I at least want you to know what I'm talking about. And I'm like, oh yeah, these arteries supply this part of the stomach. So here's where the esophagus enters the stomach. So right here would kind of be where like the lower esophageal sphincter is, and we'll talk about that a little bit more. When I have GE sphincter, it's the same thing as lower esophageal sphincter. Sometimes people write it as like gastroesophageal, so GE, but it's the same thing as the lower esophageal, so LE sphincter as well. So the cardia, this is the part of the stomach that lies immediately distal to it. So it's like the first part of the stomach. It's called the cardia because if you were to like look at where the heart is, the heart would be like right here. So that's why they're like, oh, it's the cardia. It's the heart, the part closest to the heart. Next, you have the fundus. It's a really, really small region. It does become important with blood supply. I've been asked anatomy questions about the blood supply to the fundus specifically. It really is just this tiny little portion right next to the cardia. The main portion of the stomach is the body. So this is like the main guy. It's between the fundus and where the pylorus starts. And the pylorus, this is kind of where it starts to narrow, because now we're going to enter the small intestine. We're going to enter the first part of the duodenum. There are all these different areas. It's good to know these because, so for example, the pyloric antrum is in yellow, the pyloric canal is in green, and the pylorus. Like, it's kind of good to know those because sometimes it'll be like, oh, like these cells are from the pyloric antrum. I mean, you're not going to get it wrong if you just pick a spot where the pylorus is, but just a heads up, that's why it's delineated, because it does differ a little bit in terms of like cell types and like certain pathology states. Like the antrum is affected more than like closer to the start of the duodenum or whatever. Okay, so these are the four parts of the stomach. And then, so there's two major curvatures to kind of know. There's the lesser curvature and the greater curvature. So the lesser curvature is just like, it's this medial concave border. So this is the stomach and the body. Remember, we're on the left side. This is how it's kind of sitting in the body. So the lesser curvature is going to be the one kind of facing the rest of the body. It's on the medial side. And then the greater curvature, it's just a bigger curve. That's like how you can remember it. That's like more convex and it's more lateral. And we'll talk about this as well because, again, blood supply. Like they'll ask which arteries supply the lesser curvature versus the greater curvature. I think that was actually a question on my PBL exam. It was asking about like blood supply to one of the curvatures. So I was like, this is like second order. I have to know, okay. And then back to the sphincters. So the gastroesophageal sphincter, the GE sphincter, aka the lower esophageal sphincter, which is the LES, they're both the same thing. This is basically circular muscle. that's located at the junction. So here's basically where the esophagus enters the cardia. That's where the lower esophageal sphincter is, or the gastroesophageal sphincter. And this is the main important role of the lower esophageal sphincter is to prevent that gastric reflux. Because again, if this gets weakened or something happens here, you can get GERD. And that's how people do get GERD. And again, that's why people think it's heartburn, because remember, the heart's right here. So they're like, oh, like my heart is burning. That's right, heartburn. But it's really just the reflux going right where the heart is. And then I wanted to point out, like in this picture, it shows a really good job at showing the gastric folds. These are also known as rugae. So it's just kind of like another term. And then lastly, the pyloric sphincter, this is the guy that allows, this is basically like, because remember in the stomach, I don't want to do too much physio because this is anatomy, but remember the stomach has like those segmental contractions as well, where it kind of like shifts food back and forth until it's like all nice and broken down and ready to move on. The pyloric sphincter is what basically does not allow food to go through until it's ready, until it's like nice and broken down. So that's the main role of the pyloric sphincter. So it's like, oh, it controls the movement of those gastric contents. Okay, so those are the two main sphincters, and they're both just trying to keep everything in the stomach. That's really the two roles of these sphincters. Okay, and then gastric mucosa, just to kind of go on a little bit more with the histology, because to be honest, you're probably going to need to make charts of like what cells are located everywhere within the stomach, what do they secrete, and what's its function. So I tried to do a little bit for you guys, but again, that's kind of physio. But the gastric mucosa, so this is within the lamina propria. So remember, the mucosa has those 3 layers. The lamina propria is that second layer of the 3 mucosal layers. Within that, we have gastric glands. So this is actually what's doing the secretion of stuff that can allow for those segmental contractions. So the first cell type is your chief cells. This is going to be all the way down here. They secrete pepsinogen, so they're located all the way at the base. You have parietal cells, which are very much in the middle. I've actually seen practice questions where they give you like basically a histology slide and they tell you it's a gastric gland and they point to a cell in the middle. They're usually pointing at the parietal cell. It's like dead in the middle. They secrete hydrochloric acid as well as intrinsic factor. And you'll probably cover intrinsic factor when you go over vitamins, like vitamin B12 deficiency. That's where intrinsic factor becomes important. You have enteroendocrine cells, which are just kind of like next to the parietal cells. They secrete histamine and serotonin. Mucus cells, which are going to be at the neck. So the neck of these glands, or these gastric glands, they're secreting mucus. And then you have the stem cells also located at the neck, and these can differentiate into various gastric mucosal cells. So whatever you kind of need to come from, like whatever you need more of, they can kind of differentiate into them. Okay, so this is like what a gland looks like with all those cell types. This is what I was talking about. This is just kind of like, this is an absolute need to know type of thing. Like what cells are located where, and then like so again, what cells are located where. See, so on here, it talks about specifically the antrum. It's the pyloric antrum, but they refer it as the antrum. And what do they secrete and how is it regulated? Like this is just a slide, absolutely must be known. And then a path tie-in is ulcers. So with ulcers, there's 2 types of ulcers. There's gastric ulcers and duodenal ulcers. And usually they tie in these ulcer questions with anatomy. So for example, gastric ulcers, and you'll probably cover this at some point, but gastric ulcers give you pain with eating. So they cause pain when you eat food. And again, whoever's doing that, whenever you guys study it, you'll learn why. But the likely location of a gastric ulcer is going to be the lesser curvature of the stomach. So if I draw the stomach, which sure, that can be the stomach. So if I draw the stomach, the lesser curvature is this one. So usually gastric ulcers are going to be located somewhere around this lesser curvature. And we'll learn about the anatomy, the blood supply. This is the location of the left gastric artery. So a lot of the times they'll give you a vignette, they'll describe a gastric ulcer. They won't tell you the patient has it. They'll just describe it and be like, what artery is likely bleeding? And it's usually going to be the left gastric because that's located right here at the lesser curvature. Duodenal ulcers, this is where the pain goes away when you eat food. So they say that people get hunger pains because they get pain when they're hungry. And the likely location of this is going to be the posterior wall of the duodenum. So the duodenum's here. It's going to be like behind, I can't really draw it, but like behind where the duodenum starts. but there is an artery we're going to talk about, and the artery that's going to bleed is called the gastroduodenal artery. So basically the artery that goes from the stomach to the duodenum, that's going to be the likely artery that bleeds. And again, that's how they're going to ask the questions about these guys for ulcers. Okay. Why do gastric ulcers cause less H secretion? I don't know. So gastric ulcers, they themselves, so an ulcer is just like a thinning out of the layers. So remember how they have like basically like 4 layers. When you get an ulcer, like the top layer kind of like thins out, then you can go to the mucosal. That's why it can actually start bleeding. So there's really not like less hydrogen secretion. That's actually what causes the pain, is that the stomach is still secreting that hydrochloric acid, which is making the ulcer worse, basically. But it's like the ulcer itself isn't secreting anything, if that makes sense. Does it destroy the cells? Yes, ulcers are just, they completely, again, wherever the ulcer is, it completely just imagine literally just like rubbing something until it thins out. Like that's what an ulcer is. That's why it's super painful. And that's why it can destroy wherever it is, that's where it can form. And yes, the bleeding is, so people say like if you have like random bleeding, like check to make sure that they don't have an ulcer. It's usually because wherever the ulcer is, it's going to affect an artery. Yes, exactly. So it's really not the cause. It's not secreting anything. It's just like where an artery is, and that's causing the bleeding. Yeah, ulcers are they're really cool. We can have an ulcer day. But that's the general idea. Like the tie into anatomy is they're gonna ask you what arteries are affected with gastric ulcers versus the duodenal ulcers, and it's always gonna be left gastric and gastroduodenal. Okay, so the spleen, it was on your syllabus, but the spleen is not a GI organ. It has no function in the GI tract, so I have no idea why it's there. I think it's just there because it is in the GI, like it's technically a foregut organ, so technically that's GI tract, but it literally plays no role in the GI system. It helps to break down like some old red blood cells, but we're going to go into, the spleen is like the anatomy of the immune block. It's like the spleen and the thymus, that's it, and the bone marrow. So we're going to go into a lot of detail with immuno because the spleen is chocked full of immune cells. So it's really not going to make much sense if I went into it now. So we're not going to. There's 2 types of pulp. That's pretty much it. Red pulp, white pulp. But again, I just don't think that it's going to be super, super relevant. But briefly, just because again, it was on your syllabus, it is of mesoderm origin. So it's mesodermal in origin. It is a foregut organ. It's located in the left upper quadrant underneath the stomach. And some other anatomy things that I was thinking of for like your cases, like when you palpate the spleen and stuff, you really shouldn't be able to palpate the spleen. I know in like, at least when I was in first year, it like every case, it was like the spleen is palpable. And we would all sit there like, you can't palpate the spleen. Like the program that we used, or like, you can't palpate the spleen. It's very protected by ribs 9 to 11. I'll show you a picture. It's just like really high up there. You like can't get to it. But if the patient is very slender, very thin, you can palpate it. Or if the patient has like mono or something causing splenomegaly, and we'll get into all those causes of like what causes an enlarged spleen in immunoblock. But that's, again, it's a very immune organ. It's like a very important immune organ. So, but in terms of GI blood supply, we are going to talk about the splenic artery and the splenic vein, because this is kind of like tying into the portal circulation. So the splenic artery, this is a branch of the celiac trunk that's obviously supplying the spleen. I will show you when we get to blood supply. And then the splenic vein is what drains the spleen. And since it's portal circulation, this means it goes back to the liver. And we will talk about portal versus systemic circulations. And then there's other like 2 ligaments that are kind of important for this block. So you have the gastrosplenic ligament. It tells you exactly what it connects. So this ligament is just going to connect the spleen to the greater curvature of the stomach. And then the splenorenal ligament is going to connect the spleen to the left kidney. And again, we're on the left side. Remember, the kidneys, the spleen is right behind the liver. Okay, so it's going to be on the left. No, not the liver. Oh my God, it's right behind the stomach. So we're on the left side, so it's going to connect to the left kidney. Okay, so, oh, I thought I had a picture. Actually, I did in the beginning. Let's go to it really quick. So there's the spleen. So you can kind of see how just deep it is. Like you really shouldn't be able to, I mean, unless you can get your hands really far up there, you really shouldn't be able to palpate the spleen because of ribs 9, 10, and 11. They kind of are protecting it. Sorry. Are those mesenteric structures? Which ones? Where are we? This one? Wait. Were what mesenteric structure? Ligaments don't really, so ligaments kind of arise after after the embryologic development. They actually kind of arise after when the baby is born is kind of when they start arising. I don't really know if they're considered mesenteric structure. We're gonna go into mesentery, but I get I'm not 100%, I don't know for sure if you would consider these ligaments as like mesentery. It's a good thought though. It kind of does what mesentery does in terms of holding things in order. But I don't know if they're completely considered mesentery. That's a good question, but we will talk about mesentery and what it is. Okay. And then the small intestine in terms of the histology, you're going to cover a lot when you go through certain pathology states. Especially with the embryo disorders and malabsorption pathology states, you'll go into the histology a little bit more. But at a very basic baseline, there's 3 parts to the small intestine. The first part is called the duodenum, second part is the jejunum, and then the third part is the ileum. The duodenum has 3 parts to it. So it's kind of the mucosa and the 3 layers again. It's the duodenum has 3 parts. And the second and third parts are the ones that are clinically relevant, but I bring it up whenever they come up. You need to kind of understand where is the second part of the duodenum, which I will show you. But in addition, besides just absorbing nutrients, the other big role of the duodenum is to reabsorb iron. The second part of the small intestine is the jejunum. Dow Jones Industries. I love it. Love it. Dow Jones Industries. There you go. 1, 2, 3. So the jejunum, the second part, this is really important to reabsorb folate, which is vitamin B9. And then the third part of the small intestine is the ileum. The ileum we're going to talk about a lot in immuno because there is an immune function of the ileum, but we'll come back to that. But the main thing is that it reabsorbs vitamin B12. Okay. It also reabsorbs bile acid. So when you get to bile and whatnot with physio, that's really important to understand that they're getting reabsorbed in the ileum. Because there are certain pathologies where the ileum is affected and then you can't reabsorb bile acids. And then these patients are presenting with gallstones. It's why are they presenting with gallstones? So that's going to be a path thing, but just kind of understanding what's reabsorbed here is very, very important. Okay. And then since this is the third part of the small intestine, this is the last part before you enter the large intestine or the colon. So this is what's going to connect the cecum. So it's going to connect to the cecum, which is the first part of the large intestine, via the ileocecal valve. Okay, so again, just terminology, getting your bearings above you. And then the Peyer's patches, these are immune cells in the ileum, which is super weird. There's immune cells in the small intestine, which is interesting. But we'll go over Peyer's patches, whatever, when we get to immuno and what they are. But basically, if you look at the ileum, they have these little it looks like thinning out, little layers of thinning out, and these are the Peyer's patches, and only the ileum has them. And then everyone remembers where, because they will straight up just ask, where's iron reabsorbed? It's just gonna be, this is just a kind of a need to know. Again, it's because if you get your ileum out, you need to know what vitamins to give the patient to supplement because they can't reabsorb it on their own anymore. So people remembered it iron fist, bro. You'll just hear that, people saying that randomly. And it's to remind yourself the duodenum reabsorbs iron, the jejunum reabsorbs folate, and then the ileum reabsorbs B12. Okay, so iron fist, bro. And then here's kind of so here's the stomach, here's the the antrum, the pyloric antrum, and then the pylorus, and then the duodenum, jejunum, and ileum. So yeah, and then they kind of break, because like I said, the duodenum has those 3 parts. Well, I guess there's 4 parts, but the 2 that are really relevant are the second part and then the third part. These are the 2 that are going to come up with pathology states, but I'll mention it as we get to it. And then, so duodenum, and then the jejunum, and then the ileum. And the ileum, you can't see it, but it's going to connect to the cecum over here via the ileocecal valve. Okay, so the large intestine or the colon, We'll discuss this more with pathology arising from embryo as well as Crohn's versus colitis. So a lot of the times that's where you start learning about like the histology of the colon is through like learning about what Crohn's disease is and what like ulcerative colitis is, because it really affects the colon. But briefly, the first part of the large intestine is the cecum. That's where the appendix is, and that's located in the right lower quadrant. I mention this because, again, appendicitis, right lower quadrant pain. Then you have the ascending colon, and then it switches to the transverse colon via the hepatic flexure. And then the transverse colon switches to the descending colon versus via the splenic flexure. And then the rectum above the pectinate line, that's left lower quadrant. Again, kind of like if you have diverticulitis, which is basically like an issue, a pathology state of the rectum, you're going to have left lower quadrant pain. And then the anus, again, above the pectinate line. Okay, so then this is the colon. This would be like the ileum where it's connecting to the cecum via the ileocecal valve, which is right here. Here's your appendix. And then the cecum, ascending colon, transverse colon, descending colon, sigmoid, rectum, and then they don't have anus on here, but it would be like anus above the pectinate line. Okay, so that's kind of like the organ gross anatomy. And now I wanted to kind of, because you're going to hear these terms over and over again, peritoneum versus mesentery versus omentum. And it's kind of like hard to explain what they are without ever seeing it in an anatomy lab. So if you can go to the anatomy lab, I would go, because it's kind of insane seeing these things like in a person. But I have a bunch of pictures to show them to you. But first, we're going to talk about peritoneum. So what is peritoneum? We did talk about this. I actually think these are like the exact slides from when I was explaining what retroperitoneal were when like with cardio and renal anatomy. But the peritoneum itself, remember, it's this membrane that has a visceral layer, so that's in blue. That lines all of the GI organs. So it's basically like the layer directly on the organs. That's visceral peritoneum. Then you have a cavity, so like an open area, like a potential space, and then the parietal peritoneum. It's just like the lungs. It's just like the heart, where you have like the visceral and then the like the cavity and then the parietal. So it's the same thing. But that's kind of how it looks. I don't like seeing pictures like this. I think it's really hard to envision what's going on here. But this is basically the liver. And then these, when you see holes like this, imagine like the person was cut like straight down their nose, like just straight down the middle. This would be like cross sections of all like the large intestine and the small intestine. So this is like the transverse colon, like cut just in half. Okay, so that's peritoneum. So here's like another picture of it. Again, directly lining the organs is going to be your visceral peritoneum. And then you're going to have that potential space, that peritoneal cavity. And then you're going to have the parietal peritoneum around it. And again, the big tie-in is remembering what's retroperitoneal, what's intraperitoneal. We'll talk about that. I have a slide on that. But basically, I wanted to go into next what mesentery is. Actually, I don't know if it's on this slide. It's not. So what is mesentery? Mesentery is basically where you have peritoneum that folds on itself. It's like it makes a double layer. So it's going to be all like this yellow stuff. And like the question I got earlier about like, are those ligaments considered mesentery? It's like they do kind of the same thing. These like ligaments, like splenorenal ligament, gastrosplenic, they're just holding the organs in place so they don't like just move around in the body. That's also what the mesentery is doing. It's just trying to hold these organs like in place. And again, I didn't really understand what mesentery was until I saw it in lab, because it's kind of hard to visualize, but I think this is a good picture. So it's kind of like, so remember we have the visceral peritoneum, and then there's the parietal peritoneum. Well, where they come together, it makes mesentery. It's kind of like where they like double layer, because we have visceral and parietal. I have another view of it to kind of help, but this is again, this is like so this yellow, this is all mesentery, and again, it's just holding everything in place. But I think this is a really good way to visualize it. So see like the transverse colon here, it has its visceral layer and then its parietal layer. You can see it makes like this double layer right here. That's considered mesentery. And you can almost think of mesentery as it's just like filling in the space that's there so that these organs don't move. Okay, so that's really the only role of it. It's really just there to make sure that these organs just don't shift around. But you'll see like all these organs have this double layer. That's why it looks yellow. And I think this is a really good picture of it. That's why it looks like this, because it's where those double layers come in after it like surrounds the organ and then it comes together. That's mesentery. So you can pretty much see it like in every organ here. Another picture of mesentery. So it's, again, this is just what it looks like when you, in the GI tract in like a cadaver body. And then here it is again. This is a really good picture to kind of see the actual folds, because again, it's visceral, parietal coming together, folding over each other, just kind of trying to make everything stay in place. Okay, and then lastly is omentum. Omentum was the biggest culture shock of the anatomy lab for me. So when you open up the patient, you just see a yellow. It looks like just a yellow sheet, and everyone's like, "What is that?" That's the omentum. Omentum literally means apron. It just means it really is just an apron of fat overlying all of the organs. So this is the omentum here. There's two types of omentum. There's the lesser omentum and greater omentum. It's kind of like the lesser curvature and greater curvature of the stomach. The lesser omentum is actually where the lesser curvature of the stomach is, going over to the liver. And then the greater omentum is where the greater curvature of the stomach is, just covering the rest of the GI tract. And literally you can grab it and pull it up. It's like it just sits over all the organs. It's insane. And its role is to store fat. So that's kind of where fat gets stored. Oh wait, I went back. So then a lot of the times I just wanted to keep you guys in mind, when you see a lot of pictures, the omentum has been cut away, because this is literally just what it would look like if they didn't cut away the omentum to make it anatomically correct. Does the parietal peritoneum cover the omentum? Really good question. The omentum sits over everything. So actually in this image, so see the omentum up here? So this is the omentum up here, basically. They had to cut it away so that you could see like the parietal peritoneum and the mesentery, like all like those peritoneal those peritoneal layers. You still have to cut away the omentum, because the omentum, just think of it as a drape. It's just like an apron drape that just sits over all of these things. It's kind of wild to see. Here's another picture. So again, just if you were to open up this patient, you would see the lesser omentum here just draping over everything, and then the greater omentum here draping over everything. And again, it's going to cover the small intestines like an apron. That's where it gets its name. Okay. And again, just with terminology, they can straight up ask you lesser omentum, greater omentum, and you have to know where the rough locations of those. What is the relationship between the lesser omentum and parietal peritoneum? So I didn't really go into it too much, but I guess I can. So the lesser omentum specifically is kind of so you can see it on here. They kind of even reference the lesser omentum as basically what mesentery is in the lesser omentum area. But it's kind of like the parietal peritoneum they kind of almost merge together. But if you were to cut, so they're kind of they go hand in hand is what I'm saying. But if you were to cut away the omentum, just cut it off, you could still see the parietal peritoneum. So they kind of just sit on top. Honestly, the omentum just kind of sits on top of it. And the parietal peritoneum kind of sits under it. But a lot of the times, you'll see here, they kind of reference, they kind of just label them similarly, if that makes sense. Yeah, no problem. Okay, so just really wanted to show you as many pictures as possible. I wonder if there's a picture on here. Parietal peritoneum. Yeah, so they just sit on top of each other. So you have to kind of cut it away in order to see anything that's going on under it, that mesentery layer. Okay, and then these are just slides. Again, these are straight up from the anatomy from cardio and renal. But basically, there's a noted anatomist video that goes over the peritoneum. I actually think I watched that when I was a first year in GI tract. I actually watched a lot of his GI anatomy. I think he's awesome. I love that he draws a lot of stuff. But yes, so I highly recommend noted anatomist if this is still what is all this? What are these terms? Yeah, and I think his peritoneum one is really, really good. It's just peritoneum, all organs basically have those two layers, those visceral and the parietal. One is lining the actual body cavity, the outer wall of the body, and then one is lining the actual organs. And then just you have this extra mesentery, this extra omentum, so it kind of all blends together. But if he can draw it, I think that would be really helpful. So I think that would be a good video to watch. But here's another picture of it. So again, intraperitoneal is within like within the peritoneal cavity. And then, so that would be like everything in yellow. And then extra or retroperitoneal is just outside of and behind the peritoneal cavity. Okay, so remember our favorite retroperitoneal organs. You can remember with sad puckers. I highlighted the one that's relevant for GI block. This is, again, the exact same slide from the anatomy lecture. So I highlighted acute pancreatitis. So the pancreas is a retroperitoneal organ. So you'll feel pain radiating to the back. This is like where patients will like say pain is going to the back, or like they feel pain in the back. And it's because it's retroperitoneal. And then here's kind of like the sad puckers, what it stands for. And then the first aid image, everything in pink would be like intraperitoneal. And then everything not in pink is, these are these retroperitoneal organs. What gets tricky though with the GI tract is, for example, it's like the duodenum, but it's the second through fourth parts. So like the first part is intraperitoneal. So it's just kind of like, it is kind of annoying, like the colon, except the transverse colon. Isn't the tail? Yes, exactly. The pancreatic tail. Very good. Yep. So the pancreatic tail is intraperitoneal. The head is extraperitoneal, or retro. I keep saying extra. Retroperitoneal. Yeah, so it's just kind of annoying with like all of these. You kind of have to like learn those exceptions. But pretty much everything that's highlighted is retroperitoneal. And then most of the GI organs are, there are a few that aren't, and they're highlighted here with the exceptions. Okay. Is there Anki for this? I think so. I don't remember. I know, I actually don't remember. That's going back too far for me. I think there probably is. I don't know if there is for blood supply. Blood supply, I got a lot of my blood supply stuff from like the, like for, honestly, for studying for boards. I found like that 100 concepts PowerPoint I keep talking to you guys about, which had just all of the anatomy you need to know for boards. That's what I use for blood supply. But I can't remember if there's Anki for it. I apologize. Anki is a distant memory in my brain. But okay, so GI blood supply. So same one as last time, of the abdominal aorta. Pretty much the three main like arteries are the ones that we need to know for the GI tract. So the celiac artery, the superior mesenteric artery, and the inferior mesenteric artery. And then I have their locations. This is just a good thing to know, just kind of knowing where these are, like where they're located. And like I said earlier, remember the celiac trunk, this is going to supply your foregut organs. So that's why it's good to know what the foregut organs are. Because if you're ever stuck on an exam and it like, I don't know, they ask a question, what does the celiac trunk supply? You can rule out anything that's not a foregut organ. The SMA supplies the midgut organs, and then the IMA supplies the hindgut organs. Oh, cool. So there's a section under boards and beyond GI blood supply for Anki. Thank you for looking. I will probably have to do that when I come back to third year. I have to do Anki again. Okay, so pretty much like I said, all of these slides are taken from that really high yield PowerPoint that you guys will probably get when you're second years, just for all the anatomy that's going to be covered on boards. Half of that PowerPoint was GI blood supply. So again, very, very important. It's just a very big, important concept. So the more you know now, the better it'll go. But this is just an image from that PowerPoint showing like the location of the celiac artery. It's at like roughly T12. The SMA is roughly around L1, and then the IMA is around L3. And then we're going to talk about all the branches, because you do have to know like which branches of the celiac trunk supply, you know, the stomach, the lesser curvature of the stomach, the spleen, the blah, blah, blah. So we're going to go into that now. So the first thing we're going to talk about is the celiac trunk branches. And whenever it has like a number here, I tried to match it up with like what that is. So I basically tried to make a key. And then I highlighted what I think is like absolutely must know. So just putting this in context, here's the celiac trunk right here. So again, if we go back to here, this is the celiac trunk. This is the celiac trunk right here. And it automatically branches into 3 branches. The first branch is called the left gastric artery, because remember on the left side over here, right? It's over here. So this is the left gastric artery, number 1. Number 2, going the opposite direction, is the common hepatic artery. And remember I said from last time, anytime you see the word common, you know it's going to bifurcate. It's going to bifurcate into 2 other arteries. So you have the left gastric, the common hepatic, and then the splenic. And something to note about the splenic is see how the splenic kind of goes behind the stomach. So this is, I'm drawing the splenic, kind of actually does like this little loop, and then it goes and it supplies the spleen. So that's the splenic. It's with that little loop behind the stomach, and then it goes over to the spleen. So this is the spleen, here's the stomach. So now it's kind of, we're going to go through these three main branches and see their branches, because those are the ones supplying those specific parts of these GI organs. So the left gastric artery, again, is going to be number one. It's going to basically branch into the esophageal branches, which is number two. So it goes up and it supplies the esophagus up here. This is going to be important with the portosystemic anastomoses. So that's where it's coming from. Then there's three gastric branches. So that's number three. You don't have to know the names of these, but understanding that the three gastric branches are going to basically supply this lesser curvature. So the left gastric, so basically you can think of this as the left gastric is going to come, send off its esophageal branch, and then it's going to come back and supply this lesser curvature, which is this part here. And then remember we talked about anastomoses very briefly with cardio. And remember, anastomoses is basically where two vessels connect. It's like kind of where you get like a connection between two vessels. You get a bunch of anastomoses in the GI tract. So this is one of them. And you should definitely know like the main anastomoses. I'll highlight them. This is number one. So number one is going to be the left gastric artery, anastomosis with the right gastric artery, which branches off of another artery. So we'll come back to it, but just understanding like here's anastomosis number one. Left gastric, which comes off of the celiac trunk, to right gastric, which we will talk about in a second. And then altogether, the left gastric and right gastric anastomoses supplies the entire lesser curvature of the stomach. Okay? And I actually do think I remember there was a question on our exam where it was like, which of the following is and is not an anastomosis? It was like a question like that. And it asked about these anastomoses we're going to talk about. And it's like, which one was and which one wasn't? So like which arteries did have connections with other arteries and which ones did not. So here's number one, left and right gastric, nice and easy. So that was the left gastric branch of the celiac trunk. Now we're going to go to the common hepatic artery, which was that second branch off the celiac trunk. So that's going to be this guy right here. So it's the common hepatic. And remember, like I said, every time you see common, it's going to bifurcate. So this is going to divide immediately into what's known as the proper hepatic artery right here. So it goes up. And this guy is really, really important because this is located in the portal triad. And we're going to talk about the portal triad, but you should know what are so portal triad is like, what are the three things within this, the portal triad, whatever. But what are the three things that are located here? This is the artery that's located in the portal triad. It is the proper hepatic artery. Okay. And it's a branch of the celiac trunk. So the celiac trunk branches, it branches into the common hepatic, and then it's going to go up. This is a phenomenal picture. Oh, I'm so excited for you guys to see all the anatomy pictures from this PowerPoint. It's such a good PowerPoint to learn like anatomy. I was like, why did I just see this second year? I like don't understand. So you guys are getting it first year, which is good because then anatomy will be a breeze when you're studying for boards. So celiac trunk, common hepatic, so again, common is going to split into two. The first one's proper hepatic. The second one is called the gastroduodenal. So it just tells you what it does. It supplies the stomach and it supplies the duodenum. It probably goes like that. But remember, duodenal ulcers, which artery does it usually cause bleeding of? The gastroduodenal. So this is the location usually of where these duodenal ulcers are because they usually cause bleeding from this gastroduodenal artery. And again, if you have bleeding from an ulcer, that's a complication of the ulcer. So you can have an ulcer without having bleeding, but usually the question is phrased like, if you do have like this gastric ulcer, this duodenal ulcer, which artery is likely bleeding? And it's usually the left gastric with a gastric one. So right here, it's usually the left gastric like we talked about. And then it's usually the gastroduodenal with a duodenal ulcer. Okay. And again, it's because that's like just the location of it. That's just where it happens to be. Like that's where people tend to get these ulcers. Okay, good with common hepatic? Okay, so common hepatic branches gastroduodenal as well as the proper hepatic. Proper hepatic is in the portal triad. All right, back to the proper hepatic. So the proper hepatic sends off lots of branches. So the proper hepatic, remember, so again, celiac trunk, common hepatic, proper hepatic. But note as the proper hepatic is going up, it's sending off all these branches. So what are some of the branches it's sending off? The first one is going to be the right gastric. So that's number 2. So the right gastric is going to come down here, and it's going to supply basically the rest of the lesser curvature that the left gastric is not doing. And then you can't even see where they connect, but they connect somewhere like in the middle. Because remember, celiac trunk, left gastric sends off its esophageal branches, but then it keeps coming, and then it anastomoses with the right gastric. So left gastric from the celiac trunk, right gastric from the proper hepatic, from the common hepatic, from the celiac trunk, and they just form this circuit, this anastomosis that supplies in total the lesser curvature. Okay, so that's one of the branches it sends off is this right gastric. The next branch that it sends off are these right and left hepatic arteries. These aren't really super important in my opinion, but they just supply the parts of the liver. We're going to go into like the right lobe and the left lobe of the liver. That's like what it's supplying. It's supplying the right lobe and it's supplying the left lobe of the liver. So 3 and 4, right and left lobes. Like I said, proper hepatic, this is the one that's located within the portal triad. We're going to talk about this ligament, the hepatoduodenal ligament. Again, like I said, a lot of the ligaments in GI are just there to hold things together. This is there just to hold the liver with basically where the duodenum is. So you can, it's not in this picture, but the hepatoduodenal ligament just looks like this. It would just look like this big ligament over basically where the portal triad is, but also just connecting the duodenum to the liver. Okay, so the hepatoduodenal ligament, that's like a very like common anatomy question is like, what is the ligament that contains the portal triad? What 3 things are in the portal triad? It's just, they love the portal triad. So that's what the hepatoduodenal ligament is. That's the proper hepatic is ascending in that because it's one of the 3 in the portal triad. Okay, and then finally, one of the hepatic arteries, which is just, again, number 4. So the right hepatic artery sends off this little branch. See this little branch here, number 5? This is called the cystic artery. The cystic artery is what supplies the gallbladder. So remember I said cyst is like anytime you see the word cyst, it's just like a fluid-filled sac of some sort. So you can call like even the bladder can be like a cyst in some ways. Like a lot of like anatomy terms with the bladder is cystic as well. Also with the gallbladder also has a lot of cystic terminology. So this is one of them. The cystic artery supplies the gallbladder because the gallbladder is like a little sac of fluid, basically. That's where I got its name. But the cystic artery is a branch of the right hepatic artery, which is a branch of the proper hepatic artery. Okay. Yes, I think that's everything. That's the gallbladder supply. All right. Next is the gastroduodenal artery. So remember, common hepatic. So common hepatic branches up into the proper hepatic, and then the proper hepatic sends off all of its branches. The second branch that the common hepatic branches into is the gastroduodenal. So this is the guy that's going to be implicated with duodenal ulcers, but it's going to send off what's known as the right gastroepiploic artery. So the right gastroepiploic is this one, number 2. So it's coming. It's supplying the greater curvature, as you can see here. I'm going to stop it roughly there. And number 2, anastomosis number 2, and we haven't talked about it yet, but the left gastroepiploic comes from the other direction, and it's going to anastomose with the right gastroepiploic. But the right gastroepiploic comes off of this gastroduodenal artery. And how I remembered like the gastrics, so the left and right gastric supplies the lesser curvature, and then the left and right gastroepiploics supply the greater curvature, it's a bigger word, right? Gastroepiploic, it's a greater word, so it supplies the greater curve. It's a bigger word than gastric, so it's going to supply the bigger part of the stomach, which is the greater curvature. Okay, and then so that's you can use that if you want. And then the gastroduodenal, the other thing the gastroduodenal does, which is kind of weird and it's not in the name and it doesn't really help you, but it supplies the head of the pancreas. So you can see these branches right here. So when they talk about the head of the pancreas gets its blood supply from the gastroduodenal artery, that's why it sends off these little branches just to the head. The tail and the body get blood supply from other places, but this is the more important blood supply, the one that goes to the head. Okay, so that's the gastroduodenal. So that was just the second of the bifurcations of the common hepatic. So we're still over here on this right side. Okay, now the splenic. So we're finishing up here, last one. So the splenic, this is going to be the last branch, basically, of your celiac trunk. So remember the splenic goes, it's hiding, number 3 is hiding the little twisty turn, but it's going and it's supplying the spleen. So it sends its splenic branches, which is number 2. So those are the ones going directly to the spleen. It branches to the pancreas. So this is the part of so the body and tail of the pancreas are supplied by the splenic artery. But like I said, not as important. Usually when they ask about pancreatic blood supply, they ask about the head, which is gastroduodenal. But the splenic does do the tail and the body. So you can see those here, number 3, because the tail and the body are here. And then the splenic artery, so it comes around, it twisty turns, it sends its splenic branches, and then it also sends off this left gastroepiploic branch. So the left gastroepiploic branch anastomoses with the right gastroepiploic branch, which comes off the gastroduodenal, and then boom, we have our second anastomoses. So together, these guys make the blood supply to the entire greater curvature. And then lastly, the last branch off the splenic is the short gastric. And I highlighted this because I straight up remember this being on my exam. I don't know why they love to ask about the short gastric arteries, but the short gastric arteries are the only blood supply to the fundus of the stomach. So remember when we talked about the fundus was just this little tiny portion here. And I remember I was just like, it's just important to know that. The reason why is because a lot of the times you can get little like clots in the splenic artery, which is like it just blocks blood supply to the splenic artery. And yeah, like the spleen's gonna die, but what's really bad is that just this part of the stomach will die because the only blood supply going to this part of the stomach is from the splenic artery. So that's usually how they'll word it. The short gastric branches of the splenic artery. That's like usually how they'll word it, is they'll talk about like a clot of some sort being in the splenic artery, and then it's like what part of the stomach is going to die, and it's like the fundus because of those short gastrics that just come off of the splenic, and that's the only supply to the fundus. Okay. All right, enough with the celiac trunk. So next we're going to talk about the SMA. The SMA, remember, this is superior mesenteric artery. This is the next one down in the abdominal aorta. This is going to supply your midgut organs. And importantly, what it supplies is and you can see it from this picture, it's supplying basically where the hepatic flexure starts. So SMA, so here's your hepatic, so this is the hepatic flexure through those 2/3 of the transverse colon. So remember I said, it's kind of like weird that you have to remember that it's the proximal 2/3 of the transverse colon is a part of the midgut. It's because that's what the SMA is supplying, and the SMA's midgut is a midgut derived artery. So that's why it only supplies up to the proximal 2/3, because that's all that's in the midgut. And notice on here, there's a lot of branches. I did not name all these branches. I haven't never had a single question about a lot of these branches on both sets of boards on the exam. I'm not saying you shouldn't know them. I'm never saying that. But if you had to pick what was most important out of all of these arteries, I don't think these are the most important. What I do think is important is number 7. So this is called the middle colic artery. That is actually the one that's supplying the transverse colon, the hepatic flexure. Like that is the most important one of the SMA, in my opinion. And it's just this branch of it. Remember, the SMA is going to supply all of the midgut. So those parts of the duodenum, those parts of like the ascending colon, it's going to do that as well. But importantly, that's what's supplying this part. Like the middle colic is what's supplying this part of the midgut, basically. Okay. So here's your middle colic, and the other important reason why you should know the middle colic is because of anastomosis number 3, which is with the IMA. So we'll talk about that in a second, but then the IMA, this is going to supply your hindgut organs. So remember, from the distal 1/3 of the transverse colon to the descending colon to the sigmoid colon to the rectum, all the way down, that's going to be supplied by the IMA. And that's why it literally switches blood supply from here down. So you're literally getting a switch in blood supply. This is specifically called the left colic, which I don't think it's number 7. Oh God, I didn't change that from the other one. But I think it's just number 1. I think it's just, this is the left colic. The left colic, I think the left colic does like pretty much all of this. But regardless, the left colic is the one that's going to be anastomosing with the middle colic of the SMA. And the middle colic and the left colic are going to make what's known as the marginal artery, which I know is super confusing, but it's basically, I'll just show you a picture. The marginal artery is basically where the middle colic and left colic combine. So that's where they anastomose. Here's your anastomosis number 3. But for whatever reason, they give it a name. It would be like as if they gave the left gastric and right gastric when they combined a different name. That's kind of what they did here for some reason, to be confusing. But basically, it's like you can see the middle colic is supplying basically the hepatic flexure, the transverse colon, and then the left colic. Yeah, I was like, what's the name of it again? The left colic is supplying the splenic flexure and then, parts of the descending colon. But this part right here is where you get a switch in blood supply, and this is known as a watershed region. And we're going to talk about watershed zones. watersheds are going to come up again in like when you have neuro block, but it's really important to remember the watershed zones. Very, very, very important. But basically the watershed zone of the GI tract is where the splenic flexure is. It's because of this switch over in blood supply. And I will talk about what a watershed zone is. Another name for it, I just tried to put like all the names I could see like of it. Basically, Griffith's point is the name they gave to this specific watershed zone. So if you see that, that's what they're referring to. They're referring to the transition from middle colic to left colic, specifically where the splenic flexure is. That's called Griffith's point. So I have this picture here. This is from UWorld. It was like a UWorld question I did. It was a really good, I just saved the picture because I really liked it. So there is another watershed zone that I didn't mention. It's the so it's where the rectum and the sigmoid kind of come together. We'll talk about that with when we get to hemorrhoids at the very end. It also switches blood supply. But a lot of the times when they're asking about like clinical correlations with watershed zones, it's really this one, this Griffith's point, where you have a transition from the middle colic to the left colic, aka the marginal artery. That's a watershed zone. So that's the first watershed zone. The second one is called Sudek's point, which is just the rectosigmoid junction. So where the sigmoid transitions to the rectum, it also switches blood supply. You get another watershed zone here. So here are the two watershed zone. Yes, so I'm going to clarify what a watershed is. I just wanted to kind of show them before I talk about them. Watersheds are going to come up in neuro. Actually, you're going to have watershed zone strokes. And so it's the same concept in neuro. So really understanding it is really important. And I'm going to explain it with a picture of land because that's how Dr. Scally explained it to us. And I thought that was phenomenal. So basically what a watershed is it literally comes from like farming. It's a farming term, which is hilarious. But it's an area of land that drains or sheds into like a different body of water. So basically, it's like these small little bodies of water that are draining into like a bigger body of water. Okay? That's what technically a watershed is. And the reason they call it watershed zones in like the GI tract as well as the like the brain, when you do brain blood supply, it's usually where you get a transition from one blood supply to another blood supply. It's almost like it's water shedding. It's transitioning. It's moving from one artery to the next. And so basically what this means, and I think I have it written, so I have it written here, like how would they ask about this in a vignette? And basically, you can think of watershed zones is since you're getting a transition from I wish I had two different colors, but from one blood supply to the next blood supply. So let's say this is the middle colic artery, and then this is the left colic artery. You literally get a transition. So you can imagine like this is a watershed zone because it's like this is all draining into its own water body thing, and then this is all draining into its own water body thing. That's not actually happening. It's just, again, that's how it got its name. So basically they're saying this point where you get this transition, it's really easy to lose blood supply at this exact point because you're literally getting a transition of like from an actual artery to another artery. So how this is like clinically relevant is if you have a severe drop in blood pressure. So like you have, I don't know, like ischemia in the GI tract, you just lose blood supply to like the SMA to the IMA. The part that's going to be most affected is the furthest parts away from the main water source, blood source, which would be where you get transitions from one artery to another artery. Does that make sense? So if you think of like the SMA, so if you think about the SMA and it goes and it's supplying the middle colic, and then the IMA is here, it's supplying the left colic. Well, it's sending off its left colic branches. You can think of these as like the water. I know it's like kind of backwards, but you can think of these as like these are the water sources, and if these lose blood, like or water, like right, they're losing blood, they're losing water. The part that's going to be most affected is the furthest part away from the source on both areas. And in both instances, it's right where these two meet. It's literally right where these two meet. So you can see just ischemia, just complete necrosis. Yeah, they're the furthest away from the water, like they're the furthest away from the main water supply. So that's why they're the easiest to lose blood if you were to have this severe drop in blood pressure, which would just essentially stop blood flow to like the SMA, to the IMA, to whatever. And I have here, like, you can kind of think about, so kind of thinking back to cardio, you can kind of think about this, like, remember with subendocardial, if you had like an end STEMI, and you had like subendocardial tissue, like let's say the right coronary was here, the layer that was going to be most affected was the furthest away from where the coronary artery comes, which would be the subendocardial layer. That would be the one that would literally become necrotic, because it's the furthest away from the blood supply. So if you have a heart attack, aka loss of blood, that's the part that's going to be most affected. It's kind of the same here. It's kind of like you lose blood from the SMA and the IMA, the furthest parts away of both are going to be affected. But since this is an anastomosis, so since we have it, it's like getting hit twice. You're like the furthest blood from this artery, but also the furthest away from this artery. That's what makes it a watershed zone. Does that make sense? It's kind of confusing. The same thing happens in neuro, and that you have watershed strokes in neuro, and they present very interestingly, but it's the same idea. It's like the furthest away of two anastomosing arteries from their each respective blood supplies. And then, how does blood flow through an anastomosis? Yes, they do merge. They do merge. I was just drawing this for like special effect to kind of help you visualize it. Technically, these are merging. Like they do make an entire new artery, right? They make them the marginal artery. So it does make an entire new artery, but still it doesn't stop the fact that this is from the SMA and this is from the IMA. So it's still the furthest points away from the blood supply. So technically you can only have like watershed stroke or watershed anything in an instance where you have anastomosing vessels. Oh, I was saying in a normal situation, how does blood flow through the junction? Does that cause turbulence? Yeah, I mean, you would think it would. It really doesn't. It just kind of combines, and it ends up being fine. I don't really know specifically, but I do know like these do just kind of like they do just kind of merge. But all they're really trying to supply is like what's right above it, so it's like not a big deal. It's not trying to go elsewhere, so it's like fine. I don't know too much of the specifics. But hopefully that's helpful with watersheds are. The other thing I want to mention is when you're doing vignettes, look for atrial fibrillation in the prompt. And the reason why is because remember I said this is usually triggered by severe drop in blood pressure. And a lot of the time they will give that away by saying the patient has AFib. And now they come in with like severe stomach pain. And you can think of this as like AFib, you make these clots, right? So you get these clots in AFib. They don't just always go up to the brain and cause strokes. They can also go to the GI tract. They can also go to the GI tract and cause strokes of the GI tract. And a lot of the times these strokes of the GI tract affect the watershed zones the most, like the absolute most. Okay, so look for that in a vignette, look for AFib. That'll usually, and if you're in GI block, you know it's a GI question, like you know, like they're trying to get at a watershed zone stroke. Yeah, cardio is never going away. Cardio is back. It's never going away. Okay, that's your watershed zone. And then the other thing to kind of mention, another path tie-in with the SMA is superior mesenteric artery syndrome, so SMA syndrome. We did talk about nutcracker syndrome. Remember nutcracker syndrome back in renal? See, it's not cardio, it's renal. But remember that. We will talk about it again if you're like, I don't remember that. This is kind of the GI version of nutcracker syndrome. It's the exact same pathology state. But something to understand is the SMA, branch of the descending aorta, we know this. So here's where I was talking about like the part of the duodenum that's important. The third part of the duodenum, so the third part, courses underneath of the SMA. So if you see here, like here's the SMA like this. Oh God. The duodenum, the third part of it's coming from here, it would go right underneath of it like that. Which is fine, so the SMA is on top of it, which is fine. But what happens is, remember the SMA basically is surrounded by a fat pad, and that's what keeps it elevated above where the duodenum is. We talked about this in terms of the left renal vein. If that fat pad goes away, it can basically cause what's known as SMA syndrome, or it can cause nutcracker syndrome. So here's like a picture of this. So here's an image of the third part of the duodenum. Usually, again, you have like this fat pad that's kind of like holding the SMA up and keeping it nice. But if you lose this fat pad, and usually it's like very quick weight loss, like very quick weight loss, it can crush the third part of the duodenum. And that's kind of like, if you see, I know like CT scans, you're like, but this is the SMA right here, and you can see it's really like, it's like crushing the duodenum that's under it. This is like a 14-degree angle, like crushing the duodenum. It should be a lot like more like out. And then here's another image. Remember, we talked about the renal vein. So they're showing in this instance, the renal vein is not being affected. It's only affecting the duodenum. So this would be causing like an SMA syndrome versus like a nutcracker syndrome. But if it were to crush the renal vein, you would get a nutcracker syndrome, which you will cover in repro again, because they will ask about that again. But does that make sense? So it's this aortomesenteric angle loses some of its fat pad around here, and then it basically the SMA crushes the third part of the duodenum. Okay. All right. Moving right along. So next is the liver, gallbladder, and pancreas. So through the anatomy as well as the hepatic blood supply. So the liver is an endoderm organ. So, and again, you'll kind of go into embryo a little bit in repro, but I just put it on here just to be like, okay, like that's endoderm, just kind of like start hearing it. The liver, we know it's a wedge-shaped organ consisting of 4 lobes. So the right lobe is like the biggest lobe of the liver. It's actually very, very large. The left lobe is super tiny. And then there's 2 other lobes, the quadrate and the caudate. I'll show you pictures of it. But the quadrate is the anterior surface of the liver, and the caudate is like in the back. So it's the posterior surface of the liver. And then it's located in the right upper abdomen, like I said, right upper quadrant. It's located right under the costal margin. And basically how big it is it goes from the 5th intercostal space to the right costal margin, so at the midclavicular line. Okay, so some important things to point out. Here's the right lobe. It's very big. So this is that one. So you can see front and back. This is the left lobe. I don't know why they call it the lobus hepatis sinister. I've never heard that, but that's the left lobe because this is just what the left lobe is. So right lobe, left lobe on both sides. The quadrate lobe, again, is going to be on the posterior surface here. Well, what did I say? I don't want to say it wrong. The anterior visceral surface. So it's going to be at the top, like basically where the top of the liver is, which would be like here. You just can't see it on this. Because again, they took the liver and they flipped it like long ways down. So this is like the top. It's just flipped underneath. So that's the quadrate. And then here's the caudate up here. Just kind of, again, just knowing that there's 4 lobes. And then pointing out the important ligaments. So the venous ligament is a remnant of the fetal venous duct. So remember the ductus venosus for fetal circulation. When it obliterates and it turns into a ligament, it turns into the venous ligament. And again, remember the ductus venosus. The whole point of it was to bypass blood from the liver to the inferior vena cava. The second ligament is the falciform ligament. The falciform ligament is a really good landmark. It is like the ligament that separates the right and left lobe. So you can kind of tell like what lobe you're in by looking for the falciform ligament. And then the last one, this is probably the most high yield one, is what's known as the round ligament. And the other name for it is called the ligamentum teres hepatis. So they're the same thing, ligamentum teres hepatis and round ligament, exact same thing. This is a remnant of the fetal umbilical vein. So I think it was in that one slide I had for you guys for all like the fetal derivatives, like the fetal structure and basically its derivative after the baby's born. They like to ask this one every now and then because it's just like a good landmark. You can see it doesn't really do anything. It's just kind of there. There's 2 round ligaments, right? Yeah, one is in the reproductive system. That's why I don't really like calling this. Yeah, so the round ligament, that when I hear round ligament, I actually think of like the reproductive system. That's why I don't like that they're calling it the round ligament here. This is the ligamentum teres hepatis. The round ligament in the repro system, that's the round ligament. There's not another name for it. Okay, but just keep in mind, both of these can be the remnant of the fetal umbilical vein. Okay, this is kind of what we talked about. So falciform ligament, it's going to connect the liver to the abdominal wall, and it's a very good landmark, like I said. This contains the round ligament, aka the ligamentum teres hepatis, which is a remnant of the fetal umbilical vein. The hepatoduodenal, you're going to annotate? Sure. What are you trying to annotate?
That was a mistake, my bad.
Oh, okay. How do I stop this? Okay. So the question in the chat, what other GI structures come from endoderm? Mostly all of the 4 gut organs come from endoderm. The spleen is like one of the only ones that come from mesoderm. But that's like that's like not super important, but yeah, that's like a good embryo topic. But again, yeah, most of the 4 gut organs are endoderm derived. And again, I can kind of go into that a little bit when we do embryo, like the embryo path. I'll kind of go into like, oh, this is why it comes from endoderm, or this is why it comes from mesoderm. But okay, so then the hepatoduodenal ligament, this is the one that contains the portal triad. So again, like I said, this will be like you will be asked this question. So please know that the hepatoduodenal ligament, what connects the liver to the duodenum, that's what contains the portal triad. We already talked about one thing in the portal triad, the proper hepatic artery. Okay, so we got one down, so we got two to go, which we'll cover. And then the gastrohepatic ligament connects the liver to the lesser curvature of the stomach, and it kind of tells you in the name, gastrohepatic. So the liver is here, and then the stomach is here. So of course it's going to connect the lesser curvature. This is what's containing those gastric arteries. So those left and right gastric arteries, they're going to be just like within that gastrohepatic ligament. And then the fetal venous ligament, like I said, that's kind of like the remnant of the fetal ductus venosus. Okay, so notable liver features. Everyone always forgets this, but the liver is what synthesizes bile. And I'm not going to go into bile because again, that's not anatomy, but the liver is making bile, and then it sends it to the gallbladder, and then the gallbladder stores it. Okay, this is a commonly mistaken thing. So the liver makes bile, sends it to the gallbladder for storage. Okay. The liver has dual blood supply. So it has systemic blood supply. So remember, we have the hepatic, so the proper hepatic artery, which is this guy, and it sends off all those like branches. It's going to send off those right and left hepatic branches. They're coming from the celiac trunk, which we've talked about. That's why it's systemic. It's coming from that abdominal aorta. But the liver also gets a portal like blood supply. It gets portal. So when they talk about portal system, they're talking about basically it's like, and I'll go into this a little bit more, but basically all of the GI organs get drained by portal veins, like various portal veins. So like, for example, the superior mesenteric vein, the splenic vein, like the splenic vein is going to drain the spleen. The superior mesenteric vein is going to drain all the organs that the superior mesenteric artery supplies. And so basically like those veins are going to come together and form the portal vein. So they form the portal vein. This might be like a good question too, like which two veins make up the portal vein. And then the portal vein goes to the liver. Because remember, like the whole point of the liver is to detoxify stuff. Like you need detoxification before you send it back to the heart, basically. So that's kind of what it's doing. It's taking all the blood, like the drained blood from all the GI organs and taking it and detoxifying it. So that's why they say there's dual blood supply, because there's two like vessels that are going towards the liver. One is systemic, so one's the hepatic artery. And then the second one is going to be venous blood, but it's going to the liver because it's like, here, take this and detoxify it before we go to the inferior vena cava and then go back to the heart. So I always say like this is collecting blood from the GI organs, the spleen, and the pancreas. It's just collecting all that blood before it goes back to the heart. Okay, so this is number 2 in the portal triad, but we'll talk about that. But the portal vein is number 2 because it's going to be right next to that proper hepatic artery going to the liver. And then so the liver, and we'll talk about this more, but the portal vein goes into the liver, and then the hepatic vein goes out of the liver, and the hepatic vein goes directly into the inferior vena cava, and then the inferior vena cava goes back to the right side of the heart. Okay, and I'll have pictures to kind of show you this, but just keep in mind it's dual blood supply. It's getting venous blood as well as arterial blood, and the whole point of it getting venous blood is to detoxify it before it sends it back to the heart. So we're not sending like toxic chemicals to the heart, and then that's why people die. Okay. So gallbladder, just very briefly, it's a very small organ, but like I said, remember it has the cystic. So cystic is going to be with the gallbladder. That's going to be like its like thing. There's no like gallbladder artery. It's always going to be like cystic artery, cystic duct, like that. They're talking about the gallbladder when you see cystic in the GI tract. It's comprised of the fundus, which is like the top part of it, the body, which is the main part of it, the infundibulum, which is just like a little narrowing. I think it's just like, I don't even really see it, but it's there. It's between the neck and the body, and then the neck, which is the actual part that's connecting to the cystic duct. So kind of like how this works, remember how the liver synthesizes bile and then the gallbladder stores it kind of until like you need to release it. So the liver is going to send bile down through these ducts. So it's going to send bile through the left and right hepatic ducts, okay? Then it's going to go down to the common hepatic duct, and then it's going to be like, okay, I need you to store this. So it literally somehow makes a 45-degree turn, it's probably more like closer to 90. has the gallbladder store it, and then when it's ready, then it can send out bile through the cystic duct, and then it goes down, basically all the way down here through the common bile duct. And then it's going to enter the second part of the duodenum, which we will talk about, but that's the other second landmark to know, the second part of the duodenum. Okay, so again, one more time. We have the liver synthesizing the bile. It's coming through the right and left ducts. So that's bile that the liver made, going through the common hepatic duct. And like I said, common, so we know it's going to bifurcate. And it's going to send one branch through the cystic duct to the gallbladder to store bile. And then when the gallbladder is ready, it releases the bile back through the cystic duct. I have absolutely no idea. I've looked into this too. Like, how do they not like run into it? I have no idea. No one seems to know either. But it goes in, then it goes out through the same way, and now it goes down through the common bile duct. Okay, and then the common bile duct is going to enter directly into the second part of the duodenum. So where is the sphincter of Oddi? We will talk about that. That's actually that's what's controlling the release of bile into the second part of the duodenum. But I have a better picture for that. Okay, does that make sense with all these ducts? Okay. So gallbladder, blood supply is going to be the cystic artery. Remember, it's a branch of one of those, like the right hepatic artery, which is a branch of the hepatic, like the proper hepatic artery. Venous drainage, cystic veins. We love that. And then since it's a GI organ, it's going to go back through the portal vein, back to the liver. It gets parasympathetic innervation through the vagus nerve, sympathetic through the celiac plexus. I'm going to talk about this later. I should have left this out because we're going to talk about innervation at the end. And then sensory innervation. So this is an interesting thing. That's why I put this in here. So the phrenic nerve actually innervates the gallbladder, which is super weird. But it's important to know this because remember the phrenic nerve comes from C3, C4, C5. So those three cervical levels. C3, C4, C5 also innervates some skin of like the right shoulder. It just does. It's like a dermatome, which you'll learn in neuro, but C3, C4, C5 supplies like part of this up here. So if you have gallbladder pain, I know, wild. If you have if you literally have, cholecystitis, so you have cholecystitis, oh my God, cholecystitis, you have an infection of your gallbladder, you can actually get right shoulder pain. And this is always in vignettes. I'm not kidding. If you think a patient has bile stones or like gallbladder infection, they're going to mention in the vignette that there's right shoulder pain. And it's because of this phrenic nerve that just gives some sensory innervation to the gallbladder for no reason. It's just there, honestly, for no reason. But yeah, so that's a cool tie-in. So just look for that in vignettes, look for that in your cases, like look for right shoulder pain because that could mean that they have an issue with the gallbladder. Actually, you'll learn about this in OMM. This is called a viscerosomatic reflex. So viscero meaning an organ is affected, and then it's presenting itself to the patient as like a somatic issue. So like a skin, body part issue. So this is like this would be like an example in your OMM portion of the exam of a viscerosomatic reflex. Organ, viscero, causing a somatic manifestation of the organ pain. So cholecystitis causes right shoulder pain, viscerosomatic reflex. It's in the OMM study guide. Okay, so then the liver makes bile and then the gallbladder stores bile. We already kind of went through this, but remember bile comes right and left ducts, common hepatic duct goes up somehow. It makes this crazy turn up into the gallbladder. Then it comes back out somehow without interrupting through the cystic duct, and then it goes through the common bile duct, and then it's going to go into the second part of the duodenum. So the second part of the duodenum is also where the pancreas sends some of its exocrine, like pancreatic enzyme juices, like those pancreatic juices. This is where it gets kind of confusing. This location of where the common bile duct and the pancreatic duct, the main pancreatic duct, enter the exact location where it enters the second part of the duodenum is called the ampulla of Vater. And if you remember from like the second slide, this is up to where the celiac artery supplies. Remember, the foregut is supplied by the celiac artery, and the foregut organs stop right here at the second part of the duodenum. Okay? So it goes up to the ampulla of Vater, and then it switches second to fourth parts of the duodenum are supplied by the SMA. So that switches to midgut. And again, it's all about embryo, how it was like derived embryologically. But the actual sphincter, so the actual opening closing thing that controls bile entry as well as pancreatic juice entry, that's called the sphincter of Oddi. So I put this in here. I have a picture to show you. But this is just, again, even Costanzo's like, yeah, it just kind of goes up and then it comes back down. So it's like, no one really talks about how these guys like don't crash into each other and how like it makes this crazy 90-degree angle turn. It's just something that happens. But it's making bile, and then this guy is storing bile. And then whenever it's ready, cholecystokinin, that's what's kind of telling it, hey, contract, so we can have some bile. And then we talked about bile reabsorption in the ileum. Here you go. So here's another good picture. So you can see here, so this is a better picture. So common bile duct goes into the ampulla of Vater. Main pancreatic duct also enters through the ampulla of Vater. And that's where it's not labeled on here, but that's where the sphincter of Oddi is basically. So the sphincter of Oddi is kind of like the exact sphincter that controls pancreatic juice as well as bile juices into the second part of the duodenum, aka the ampulla of Vater. I have no idea why it's called the ampulla of Vater. Okay, but does that make sense? So that's going to be like, they'll just throw that terminology around. They're at the exact location. It's just like the sphincter is the actual one controlling. The ampulla of Vater is more of like a landmark. It's like, oh yeah, it's at the second part of the duodenum where all these ducts enter. That's the ampulla of Vater. Okay, and then the hepatoduodenal ligament, this is what's containing the portal triad. Oh, I didn't give you guys the third in the portal triad. Oh man, okay, we'll talk about it next. But we talked about two already. Remember the proper hepatic artery and the portal vein. Those were the two that we had mentioned. But we'll talk about the third one on the next slide. But remember, the hepatoduodenal ligament is what's containing the portal triad. So remember I drew like a square, and I'm like, oh yeah, this is the hepatoduodenal ligament. It's just, again, all these ligaments are just for like holding things in place. The hepatoduodenal ligament is just trying to hold this portal triad in place as it connects the liver, hepato, to the duodenum, hepatoduodenal. The hepatogastric ligament connects the liver to the lesser curvature of the stomach, hepatogastric. Altogether, this makes up the lesser omentum. So sometimes like an anatomy question would be like, what two ligaments make up the lesser omentum? And it's these two. And again, it's not stuff you need to memorize. If you just think about the names, you know the lesser omentum is where the lesser curvature of the stomach is. So you can kind of derive what the two ligaments are that would make that up. But the hepatoduodenal ligament contains a portal triad. So what's number 3? The common bile duct. Oh. Behind the lesser omentum is retroperitoneal. Behind, hold on, let me think. There's actually a name for the area. Go back. Oh. So there's actually a name for the space behind. Yeah, so we'll talk about that. Okay, sorry. Yeah, we'll talk about the name of the space behind the lesser omentum. That can be asked sometimes too. I have a slide on that to show you. I have a really good picture. I'm like, oh, that's what it looks like. But this guy, the portal triad, hepatoduodenal ligament connects the liver to the duodenum. We have the proper hepatic artery, which we talked about. This is remember, this is coming from the celiac trunk. This is bringing the blood supply to the liver. Remember, it branches off into the left and right hepatic arteries. The right hepatic sends off its cystic artery. It also goes down and supplies like the gastroduodenal artery. So it's doing all sorts of stuff, this proper hepatic artery, but it's number 1 in the portal triad. The second one is the portal vein. And remember, like I said, the portal vein is basically taking all of the venous blood from all of the GI organs and bringing it to the liver to be like, here, detoxify this before we go back to the heart, because I don't want to bring a toxic element to the heart. So it also brings it to the liver. So this is the dual circulation of the dual supply of the liver. So these two are both ascending. They're both going up towards the liver. And then the last thing is the common bile duct, which I did not point out last time, but that's okay. So the common bile duct, remember, it's where when bile's ready to come out of the gallbladder, when cholecystokinin is like, hey, release some bile, that's where it's going to come down and then enter through the common bile duct and then go to the ampulla of Vater, like down here or whatever. That is number 3 in the portal triad. Okay, so definitely knowing what's in the portal triad, knowing what ligament it's contained in, super important. And then understanding like if it's going up or if it's going down, like which direction is the blood and bile flowing. Okay, and then pancreas. So The pancreas, there's the head, the neck, the body, and the tail. The head, remember, has its own blood supply. It gets supplied by the gastroduodenal ligament, and then the tail and the neck and the body get supplied by basically a branch of the splenic artery. But the head, what I wanted to point out was the head is located within what they call the duodenal curvature. So this is the pancreatic head. And so what's interesting, and this is like a cool clinical correlation, if you have like a pancreatic tumor at the head, so like let's say you have a pancreatic cancer right here at the head of the pancreas, it can present with what's known as painless jaundice because you're blocking the bile duct. So you block this bile duct, so basically you can get jaundice from this, but this is in an area that's not innervated by like somatic innervation. So the patient, that's why a lot of people don't know that they have pancreatic cancers because they can't feel it. It's not like sticking out anywhere. It's kind of like hidden within all of these organs, and it's not innervated by any like sensory innervation at all. So they call this I don't even know how to pronounce it, Courvoisier's sign, and it's basically anytime you have painless jaundice with like basically a pancreatic cancer tumor, and it's because it's blocking basically the common bile duct, which is interesting. So that's that. And then the neck is just the next part of it. The body is just the next part of it. And then the tail, an anatomy tie-in is they can ask like, what ligament is the pancreatic tail in? It's located, and it's weird because pancreas is not in the name, but it's located within the splenorenal ligament. And the splenorenal ligament is an intraperitoneal structure. So that's why the entire pancreas is retroperitoneal besides the tail. It becomes intraperitoneal, which is super weird. It's because it's within that ligament. Okay, and then liver histo is important. So the functional unit of the liver is called a hepatic lobule. It's like this hexagon, so like a stop sign. It's like this hexagon. I think that's a stop sign. But anyway, and basically all these lobules are separated from each other by like all this connective tissue that would be like connecting it to the next one. Something to notice is there are portal triads located at each vertex. So if you were to kind of take this out and look at it as like an actual octagon, the vertexes are all the points. There's a portal triad at every point. And then in the middle is what's known as the hepatic vein or the central vein. They're the same thing. So central hepatic vein. And a lot of the times this is where people always get confused. They draw the liver. Remember, in the portal triad is going to be the portal vein. But leaving the liver to go back to the IVC is the hepatic vein or the central vein. They're the same thing. Okay, so don't confuse those two. One is going towards the liver, one is leaving the liver. And then the parenchyma, so the actual functional cells of the liver, are hepatocytes. And this is I actually think they asked this because they tied it into biochem, like basics of biochem. And it was like these hepatocytes have tons of what organ, like what organelle, that's the word, what organelle. And they have tons and tons and tons of smooth ER because the role of smooth ER in cells is to detoxify. That's literally its role. So the whole role of the liver is to detoxify. So you can imagine these hepatocytes have so much smooth ER in it because they're constantly detoxifying. Trying to tie in some biochem. So this is just another picture of what it looks like. So again, we have our little octagon. At each vertex, we have a portal triad, and then in the middle, we have our central or hepatic vein. With cirrhosis, these are destroyed. Yes, we'll talk about cirrhosis in 1 second. But yeah, in cirrhosis, all of the hepatocytes are destroyed. So like every single one of these little guys gets destroyed with cirrhosis. Yeah, cirrhosis is not great. And then we're gonna go into this a little bit more, but like I kind of talked about, we have the blood is flowing up from the portal triads towards the central vein. So you can see them going like that, and along the way they get the blood gets detoxified. So it's like as they're going, so like these hepatocytes that are lining it, kind of detoxify as it's going along, and then you can see there's these little they're called bile canaliculi or bile canaliculus. These are little baby bile things that are gonna eventually form together to make your bile duct basically. Well, it's the hepatic duct, the right and left hepatic ducts at first, but they're coming from these little and I think I have a better picture. Yeah. So you can see they have these little, each cell has its own little bile canaliculi that eventually is going to form into the bile duct eventually. And that's what's leaving the portal triad, through that bile duct. So cirrhosis. So with cirrhosis, actually, I think I have a slide on it later, but yeah, I'm going to wait till later, but note again, the vertexes all have portal triads, the middle has a central vein, and then blood is going to come like this to get detoxified as it goes to the central vein. And then there's all these zones. So there's all these zones here, and so we're going to talk about those zones. But first, what I wanted to mention is, oh yeah, I wanted to point this out because you guys just did renal, and remember renal was like basolateral apical, and is like one was facing the basement membrane, one was like on the opposite side. So hepatocytes have basolateral and apical, but they're different from renal. So I put like forget your renal cells because they're different here. So your basolateral portion of a hepatocyte is facing the sinusoids. So that's why I have like this zoom in, but also this one. So they're actually facing this like the sinuses that are going towards the central vein. The apical side is facing the bile canaliculi. So again, and remember, that's the whole point, is trying to grab some of that bile because it's making bile, and then it's going to send it through the bile duct down to the gallbladder for storage. Okay, so again, like this would be like the basolateral side, and then this would be like the apical side here and apical side here. So it's a little different from renal. So just don't get, that's like a little histo thing, is like basolateral is facing the sinus, so it's facing the blood, and then the apical side is facing the bile ducts. It's like a weird polarization that it has. And then here's just another picture. I kind of like seeing it like this. So this is like this, because again, it's weird. It's like on one side, and then on the side directly next to it is basolateral apical. So this is showing you, this picture is basically showing you like the basolateral sides really nicely because they're all lining the sinusoids, right? But then if you kind of zoom in a little bit, these are the portions of the cell. These are the apical portions of all these hepatocytes that are facing the bile canaliculi. And you can see all this green is all bile canaliculi. They all kind of come together and then go into the bile duct. And then another important like anatomy concept to understand, but hopefully it makes sense, is that bile flow is going to run in the opposite direction of systemic and portal blood flow. We know that because of the portal triad. 2 are going towards it, 1 is coming down. The portal vein and the proper hepatic artery blood is going towards, because again, we're detoxifying, we're going towards the central vein, hepatic vein, and then bile is going the opposite direction because we want to send it down to the gallbladder, so it's going to be moving in the opposite direction. And then this is like all the functions of the liver. So this is kind of why you do biochem this block, is because the liver does pretty much all of the biochem things. But something I wanted to point out, because you guys can like read this on your own, but the liver synthesizes like lots and lots of proteins. So a lot of the times when patients have cirrhosis, they can't make albumin anymore, and that messes with the oncotic pressure, and you can get ascites, like you can get like fluid, like you can mess with those Starling forces, and that's why you can get Starling forces issues with liver damage, because you can't make albumin anymore. So I just wanted to point that out. It's a lot of stuff we're going to be talking about in the future. The liver's making like a lot of the proteins in the body. And then also the liver stores fat-soluble vitamins. So fat-soluble vitamins, that also is important for this block. Vitamin A, D, E, and K, should definitely know that these are the fat-soluble vitamins. They just get stored in the liver because they're fat-soluble. You can't like pee them out. I think that's all I want to mention for now. Okay, and then this is the 2 types of cells that are like unique to the liver. The Kupffer cells, weird name, but these are basically like liver macrophages. We're going to talk about macrophages in immuno, but they basically like gobble up stuff that shouldn't be there. They're basically just like immune cells of the liver. They're called Kupffer cells. And then stellate cells. So stellate cells, another name for these are called ITO, ITO. So like ITO, they're the same thing. So stellate/ITO cells, these are the ones that are actually storing the vitamin A. This is like a weird fact that should be known. So the stellate cells are storing vitamin A when they're not active. So when they're like just chilling, not really doing anything, they're storing vitamin A. When they're active, what they do is they secrete extracellular matrix. So they produce a lot of extracellular matrix, but they do this post-injury. So this is like when the stellate cells would get activated, is after an injury. These are the ones, and this is what I was mentioning with cirrhosis, we'll talk about it. These are the cells that are responsible for cirrhosis, because basically they think the liver is just damaged always, and they start producing tons and tons of extracellular matrix, and that's where you get this fibrosis, and that's what causes cirrhosis. So a lot of the times you can get cirrhosis from just liver damage, from, like crazy alcoholism, hepatitis, like anything can really cause cirrhosis. But what's happening is these stellate cells think that there's injury. So it's just laying tons and tons of extracellular matrix, and it's just like basically scarring. You're just causing the liver to scar. So everything kind of gets damaged. Okay, and then those three zones. So this is kind of another important, it's like all important, right? But these are kind of like, so remember in those little octagon stop sign things? Oh my God, I tried my best. So we have oh my God, the triads at each vertex. So we have all of these, and they make their way towards the central vein or hepatic vein. So zone 1 would be closest to it, zone 2 would be in the middle, and then zone 3 is closest to the hepatic vein. So you should know what these zones are and what they like interesting facts about them. I put them here. So zone 1 is periportal zone because it's next to it's around the portal triad. It's like right next to the portal triad. So that's your periportal zone. This obviously is the best oxygenated one because it's right next to the oxygen. Just tons of oxygen is there. And therefore, it's most resistant to ischemia. It's again kind of like cardio. It's making a comeback. If the coronary artery gets blocked, the one right next to it is fine. Well, blocked, not 100%. But the one that gets kind of screwed is the subendocardial, which is way down here because it's the furthest away. So you can kind of think of it like that. Zone 1 is most resistant to ischemia because it's the closest to the portal triad. So I say zone 1, first to receive oxygen. Hepatitis loves to infect zone 1, loves to infect it. So that can be just like a random fun fact to know that hepatitis likes zone 1. Zone 2 doesn't really do much. It's literally called the intermediate zone because it doesn't really have a function. It's just in between the two important zones. But the clinical tie-in with this is yellow fever. So there's a yellow fever virus. It infects zone 2. So people remember it was zone 2, yellow fever. And then the third zone is the centrilobular. So it's like around the central vein or the hepatic vein, whatever. It's around the center of the hepatocyte. This is obviously the least oxygenated, so it's the most susceptible to ischemia because it's the third to receive oxygen. But this is the most sensitive to metabolic toxins. So see how each zone kind of has its thing? This is its thing, is it's most sensitive to metabolic toxins. So for example, something like alcohol. Alcohol is like toxic to the liver. That's why it's kind of like it's really messing with zone 3. Acetaminophen, Tylenol, like hopefully, well, maybe not, but the Tylenol is very bad for your liver. And it affects zone 3. And the reason why is because you have this group of enzymes there called cytochrome P450 enzymes. These are like the big ones that are doing the detoxification. You'll go into cytochrome P450 enzymes a lot second year because a lot of drugs mess with cytochrome P450. But there's cytochrome P450 enzymes throughout the entire hepatocyte, but there's a lot of them next to the central lobular zone. So that's why it's most affected by metabolic toxins, things that need to be broken down and detoxified. That's why zone 3 is the most affected by those. And then if you were to kind of look at it, so if I kind of turn this, it's really hard to tell where the switch is. I don't even really know, but the portal triad, zone 1 is going to be right next to it. The central or hepatic vein, zone 3 is going to be right next to it. And then zone 2 is just going to be in the middle. Another picture just kind of showing like the 3 zones. Just tried to show as many zones as possible. Okay, and then this is really cool. This is Pringle's maneuver. So Pringle's maneuver is, and this is this is what the picture I was waiting for. The left, oh my God, the lesser omentum, which remember, hepatoduodenal ligament and then gastrohepatic ligament makes up the lesser omentum. Behind it is called the epiploic or Winslow's foramen. And I really like this picture. You can kind of see behind it. There's like this little space basically behind both of these ligaments. And it's just another landmark. It's called the epiploic or Winslow's foramen. I think that's an Anki. I think that's why I'll never forget it. But okay, so Pringle's maneuver is really cool. So Pringle's maneuver, I'm going to set the scene for you guys. So you open up this patient, they're bleeding they have a GI bleed. And you're like, I have no idea where this bleed is coming from. You're like, they're bleeding somewhere, but I don't know where. The first thing the surgeon usually does is he clamps the portal triad. He'll clamp the hepatoduodenal ligament. That's called Pringle's maneuver, just clamping. So he puts like this big thing and he clamps it. And what that does is it's basically stopping all of the blood supply going to the liver. So it's stopping the portal venous system as well as the systemic blood supply to the liver. Okay? So it's stopping all that. The idea behind this is if one of these like places in the, GI tract is bleeding, the bleeding should stop if you clamp if you clamp the vessels, the bleeding should stop. If you clamp the vessels and they're still bleeding, there's only two other sources that blood could be coming from, and it's either the hepatic vein or the inferior vena cava. Guaranteed question. Exam, boards. This is a really good just anatomy question. But hopefully that makes sense. So here's a picture of Pringle's maneuver. The clamp is over the hepatoduodenal ligament. Let's say the bleeding stops. It's either going to be portal vein or proper hepatic artery as the source of the bleeding. Let's say you clamp it and the bleeding continues. Absolutely without a doubt, it's either the hepatic vein or the IVC, because that's the only other two arteries, no, they're veins, the only two veins that there's blood there, but they're not being stopped by clamping the portal triad. Why would bleeding stop if you're clamping after spot of bleed? Well, because all of the arteries in the GI tract go through the so basically all of the venous blood in the GI tract is going through that portal vein. And then all of the blood that would be supplying, the liver, whatever, would be going through this proper hepatic artery. And this is where the bleeding is. So it's kind of like, I guess it's you're not really considering the small intestine, you're not really considering those guys. It's more of these organs up here. If there's a bleed up here and you don't know where it's coming from, if you can't see the source. Because remember, nothing's labeled and nothing's color-coded when you open up a patient. So this is just kind of a quick way to be all right, let's just do it super quickly and see if it stops bleeding. Because again, all of the blood is going to be going through this liver. So if you stop it, blood will stop. It's not flowing, there's no bleeding if it's not flowing. So blood just kind of stops. You don't do this for that long, so the patient doesn't die of ischemia. But you just do it very quickly and see if bleeding stops for a second. Make sense? I'm assuming it's a lot easier if I actually saw this in my surgery rotation, which I have not gone on yet. But apparently this is, according to my friends, this is a thing that they have helped with, and it's really cool. You just it takes 1 second. They clamp it, and then the bleeding either stops or they clamp it, and it's gushing blood still. And they're all right, it's hepatic vein or IVC. Okay, cool. Okay, so I'm not going to do the portosystemic anastomoses, even though I think that these are very important. I'll put them in a future PowerPoint because they're already done. But what I did want to mention was I wanted to talk about the pectinate/dentate line because there's tons of questions that can come from this. So the reason I kept saying above the pectinate line or below the pectinate line is because there's two different embryological origins above and below the pectinate line. And the pectinate line is it's not really a line. It actually kind of looks serrated like this. That's where it got its name, dentate, because they say it looks like teeth. That's what they say. It kind of looks like teeth, I guess scary teeth, but the pectinate/dentate line it's just kind of that's where it transitions from endoderm to ectoderm. And again, it's all because of embryo. It's the different, literally different embryologic structures gave rise to everything above the dentate line and everything below the dentate line. Got teeth at both ends. Yes, you do. Got teeth here. Who thought, right? You got teeth in the rectum. But the reason I really wanted to talk about this is because just imagine all of the questions they can ask about this. So first, I know we didn't talk about hemorrhoids because that's one of the portosystemic anastomoses. But hemorrhoids, for example, if you have hemorrhoids above the pectinate line, they're considered internal hemorrhoids because they're above that line, but they're not painful. You will not feel any pain with internal hemorrhoids. And the reason why is because the innervation, you can see here, it's visceral innervation. Anything that has visceral innervation, you will not feel, because visceral innervation is what's going, the parasympathetic going to the organs. You're not going to feel epinephrine, you're not going to feel basically hormones binding to receptors on organs. You don't feel that. That's visceral innervation. So that's why internal hemorrhoids are not painful at all. They're endodermally derived. It has a different blood supply, it has different everything. External hemorrhoids, so the ones that are actually the ones that you can physically see, they're below the pectinate line. they're innervated by somatic innervation. Somatic innervation is like you feel that. That is something you feel. So these are painful. And a lot of the times this can help you like a lot of the times they'll probably ask a question about like, the artery or the venous supply, something like that, but they're not going to tell you what type of hemorrhoid they're talking about. They're going to say there's painful hemorrhoids versus not painful hemorrhoids. And you need to know like, oh, if it's not painful, that's above the pectinate line. They're talking about these arteries and these veins and these lymphatics and this innervation. Like that's kind of what it's trying to get at. And then the external hemorrhoids have a completely different innervation, completely different blood supply, completely different venous drainage, completely different lymph nodes. And it's not even like subtle differences. It's like external hemorrhoids go back to the inferior vena cava, internal hemorrhoids go to the portal vein. So it's just very different. And this also makes sense for different types of metastases because again, like for cancers, like they're going to go where the lymph nodes are. So and they're going to go where or if it's a blood cancer, it's going to go where the venous drainage is. So you can imagine like if you have internal hemorrhoid, like some sort of cancer above the pectinate line, it might go to the liver. If you have cancer below the pectinate line, it's going to go somewhere else. It's going to go to the systemic circulation. So like I said, you can just already see the questions that they can ask about this. I do have a question in this. We're not going to do it because we didn't cover it in that much depth, but straight up it'll be like it'll describe a hemorrhoid of some sort, and then it'll ask what's the venous blood supply, like what is the venous drainage of this. And you need to know, like if you remember, like you remember this order and this order, but you need to be like, oh, which one was for above, which one was for below, which one was painless, which one was painful. They love this stuff, like absolutely love this stuff. But oh, I had stuff. Okay. So 2 different embryo origins, endoderm above, ectoderm below. Where they meet, that is the pectinate/dentate line. And then the cell types are going to differ because again, 2 totally different types of like embryologic origins. So the rectum above the pectinate line is going to be columnar epithelium. Below it, it's going to be squamous epithelia. And if you remember, above, you get adenocarcinoma, which arises from columnar cells. And below it, you get squamous cell carcinoma, which arises from squamous cells. So it's just, again, the tie-ins, unbelievable. And then lastly, the sites of metastases are based on that venous drainage. So remember, above goes back to the liver, below goes back to the IVC. But what's interesting is since above it, it's going to the liver, it will be subjected to first pass metabolism, meaning the liver is going to see it and detoxify it before going back to the heart, versus something that goes directly to the IVC. It's not getting metabolized by the liver. So they say that this bypasses first pass metabolism. And then I made a little chart so you guys can go through this. This is basically, again, just the really important thing to understand is above and below is how they describe it in vignettes, and how they'll describe it in vignettes is if you have painful hemorrhoids or painless hemorrhoids. And then a few quick slides on innervations. So this is excluding enteric innervations. So I didn't, because I kind of already went into that a little bit with the Meissner's and Auerbach's plexuses. And we'll talk about that a little bit more when we do like embryo path. But this is just strict sympathetic, parasympathetic. This will help you for GI. This is like actually what you guys are going to be doing in GI is like learning all of these. But sympathetic innervation, again, you'll go into way more detail in neuro. But basically what they'll say is sympathetic innervation, it comes from the thoracolumbar region. So it comes from like the thorax and the lumbar regions. But specifically for the GI tract, it's basically T5 to L2. And I broke it up into the levels that you need to know for foregut, midgut, hindgut. So foregut organs get sympathetic innervation from T5 to T9. They have short preganglionic fibers, which I know doesn't really make much sense right now. I promise it will in neuro. And then they synapse on what's known as these ganglion. Luckily, the ganglion have the same name as the arteries for the foregut, midgut, hindgut. So this one right here that goes to the foregut organs is the celiac ganglion. This one is the superior mesenteric ganglion, and then this is the inferior mesenteric ganglion. So T5 to T9 send like just sympathetic branches out to this celiac ganglion, and then the postganglionic fibers are really long, and they're going to go synapse on all the foregut organs. So again, like I said, really good to know what the foregut organs are, what the midgut organs are, blah, blah, blah. T10 to T11, these levels will synapse on the superior mesenteric ganglion, goes to the midgut organs, and then T12 to L2. Just note, sometimes I see L3 It doesn't really matter, but just know it's either like, L2, L3. Sometimes I'll do like L2/L3 because it like just varies. But these guys will synapse on the inferior mesenteric ganglion, and those go to the hindgut organs. So that's sympathetic innervation. Parasympathetic innervation, watershed, oh God, watershed sympathetic nerves. No, no watershed. Luckily. There is kind of like, remember I mentioned Hirschsprung's very briefly earlier. That's what Meissner's plexus. That's kind of like, it's not really like a watershed nerve issue, but it's like you don't have Meissner's plexus, and this is kind of the pathology that arises. I do like the idea of watershed nerves, but there is no such thing, unfortunately. So parasympathetic innervation is luckily only the vagus nerve for most of these, and then there's also the pelvic splanchnic nerve. So pelvic splanchnic is the other part of the parasympathetic. Remember, parasympathetic is craniosacral. So cranial is the vagus nerve, and then sacral is the pelvic splanchnics. And you'll learn a technique in OMM where you target the sacrum, like literally you're targeting the sacrum, and you're going to be talking about in your blurb how you're trying to regulate the pelvic splanchnic nerves, because that's what's coming out of the sacrum. But regardless, the vagus is pretty much going to innervate all of the foregut and midgut organs, but this is parasympathetic innervation, so your rest and digest. These have really long preganglionic fibers and then really short postganglionic fibers, so the opposite of sympathetic. And then same with the pelvic splanchnic nerves. These come from S2, S3, and S4. And then these will synapse on basically the hindgut organs. Here's both of them together. So we have the pelvic splanchnics, the vagus for the parasympathetic, and then we have all those ganglions and whatnot from basically T5 to L2, L3-ish area for the sympathetic innervation. And it just separates celiac ganglion, foregut, superior mesenteric, midgut, and then inferior mesenteric hindgut. And then sometimes they will want you to know what, so the preganglionic, when they're mentioning preganglionic for the sympathetic, they're talking about before this ganglion, before this celiac ganglion. That's the preganglionic fibers. They're really short. All the preganglionic fibers are is like T5 to T9, T10 to T11, T12 to L2. Those are preganglionic. The postganglionic gets its own names, and those are here. I put it in a chart for you guys. I would just know them. It'll help you for OMM anyway. But the postganglionic fibers are after the ganglion, after the celiac ganglion, superior mesenteric, inferior mesenteric ganglion. So greater splanchnic, lumbar colonic, I guess, and then hypogastric. Those are the postganglionic. Yeah, so lesser and least, 100%. I actually put lesser and least in the chart that I made for you guys. So this is just more names, because why not? But I'll show you in the chart that I did lesser and least. So just kind of adding to our picture from like the first slide. So I had what it was supplied by in terms of the celiac like what artery it's supplied by off of the abdominal aorta. What's the parasympathetic innervation? What is the sympathetic innervation? And then same thing for the midgut, and then same thing for the hindgut. So again, really important to know what's included in all of these organs. In all of these, like what organs are in the foregut, which ones are in the midgut, because you can pretty much answer these for any of the questions. And honestly, on Comlex OMM questions were a lot of this. And it was just like, what artery supplies the duodenum? And it's like, okay, like, if you know that it's a midgut organ, like the part of the duodenum they're talking about is midgut, you can kind of figure out the rest of the answers. And then here is the chart. So I did greater, lesser. Oh, I didn't do least. I did lumbar. But greater, lesser, least/lumbar, doesn't matter. There's a bunch of different sources on it, but that's what it's talking about in terms of the ganglion. When they're talking about the ganglion, it's like the celiac ganglion, superior mesenteric ganglion, inferior mesenteric ganglion. And then, like I said earlier, the referred pain. So remember, I showed you guys that big, like with all the quadrants, like the 9 quadrants. If you have foregut pain, the referred pain, like the patient's going to say, oh, I have pain here, and they're going to point to their epigastrium region. Midgut, they're going to point to their umbilical region, and then hindgut, they're going to point to their hypogastrium region, which again was just like middle, top, middle, and then middle, bottom. Okay, we made it. I think I want to do at least like 2 questions at least, and then I'm going to skip the one about the hemorrhoids, and then I'll send these to you guys, and you guys can do them on your own. But we'll do 2 because it's after 9. Give you guys like 10 more seconds. Okay, so this one, like I said, they will 100% ask you this question. Um, there is a ulcer and it's a gastric ulcer. So what location is that the lesser curvature of the stomach? That's kind of how they'll word it. They could change this to ask, they'll say there's an ulcer in the lesser curvature. What artery is likely affected? Like I said, not all the time is it the exact artery. This one was the right gastric, so it's probably in like a slightly more right location, this ulcer. But if they don't give you an option, like if they don't tell you, it's usually just going to be the left gastric. But awesome. Great job. Okay, and then one more Boards and Beyond question. Okay, I'll give you guys like 10 more seconds. Okay, so I'm very proud of you guys. No one got on this one. Very proud. So they did Pringles and the bleeding continued. So we know it's only got to be one of two possible ones. They're never going to give you both. They will never give you both in the answer choices. So inferior vena cava, very good. None of you guys got with hepatic artery. If this said hepatic vein, this could have also been correct. But remember, the hepatic artery is in the portal triad, so this would have gotten clamped. So this got clamped, this got clamped, this got clamped. This is I think they like this so much because this is like you need to know what's in the portal triad, you need to know what else would be supplying blood there, and etc. But this is literally where I got the picture from that. But okay, I think that's good for today. There's a lot more, not a lot more questions, but there's more questions in there. So definitely give those a shot and let me know if you guys have questions about them. Guys are so welcome. Oh, good. I'm so glad you guys, yes, I'm so happy. All right, I will send this, well, I'll upload it. I'll upload everything into that drive. Oh, I love watch parties. Let me stop recording.